and Ranjana Joshi madam as an expert. She is not there. हैं? कितने हैं? 3, 4, 5, 6 लोग हैं. एक माइक वहीं चाहिए ना.
वहाँ पे 2 माइक चाहिए.
दो माइक वहाँ. हाँ, एक चलेगा. घूमना है तो ये दो वहीं रख दो ना, चलेगा.
इधर बैठ जाइए ना.
So, should we start? Yes. I never learned from someone who agreed with me, and if two people agree on everything, then one of them is not required. So let us say in panel, they are agree with each other in all the time, or they will be differing in the situation. So,
Yes. So, is it worth discussing here? What we are dealing with now, is it worth discussing? Can any of you, one of you?
any of medico legal issues, is it worth discussing?
मैडम थोड़ा पीछे.
मैडम आप थोड़ा पीछे चले जाएं तो ठीक रहेगा, क्योंकि ये सब दिखाई नहीं दे रहा.
Because any medical legal, we know in our field what obstetricians are facing day in and day out. So, is it worth, any one of you can take this?
Yeah, absolutely. It is very important.
Be loud, loud.
Yeah, it's very important to discuss regarding the medico-legal issue in our day-to-day practice, especially with the patient and the patient relatives, so that they get aware regarding the condition in whatever it may be, obstetric, gynecology, or any field. But I think they are supposed to get the awareness, the education, and the prognosis, and especially the surgical procedure, the related complication, and the outcome we have to.
Yeah. So anybody can face these sort of complications. Sir,
So
yes.
it is very obvious that this type of discussion is very much necessary in this era of CPA where we practice. Because previously, as far as medico-legal part is concerned, तो एक काम ये करो ना, 2 दिन को ऐसे बिठा दो कि स्क्रीन ऑब्सक्योर ना हो. हाँ, दो तीन यहाँ आ जाइए, यहाँ आ जाइए. So now it has become very essential to include any medico-legal discussion in any of conference, any of webinar, CME, etc. And that is why it is very much necessary, and it is very obvious that medico-legal litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first as far as medico-legal problems are concerned. मैडम ये स्क्रीन ऑब्सक्योर हो रहा है, स्क्रीन इसीलिए यहाँ रखे थे 2. अच्छा, तो इसको जरा ऐसे कर सकते हैं, हैं? ये इस स्क्रीन को जरा ऐसे कर सकते हैं.
Okay.
ऐसे दिखाई तो दे रहा.
Yes, sir.
So today's topic for discussion, death on table, and we know it is a very troublesome situation for any gynecologist or any doctor rather, because when we are happily enjoying our surgery or delivery, and when ECG tracing like this, we are happy, but many a times suddenly our anesthesiologist or person will say that it is getting straight line, and then all the problems start. And when it is straight line, naturally we see. So in this type of situation, what could be the first reaction on part of any treating doctor? Sudden straight line on ECG tracing.
Yes, madam.
Yes, anybody can take.
Sir, mercifully, death on table is a very rare occurrence. But definitely a surgeon or anesthetist at least face this situation once in his or her time.
Yes.
So when we realize this situation that, okay, it's going to have a death on table, so definitely it has a considerable professional and psychological consequences on the part of the surgeon and the doctor, surgeon and the anesthetist. So here most apparently the anesthetist is affected. So we need to call for help.
Madam, you are not affected?
Mostly, no, I think anesthetist is the first one.
Yeah,
but
we want your point of view first.
And as
Yeah.
soon as any anesthetist will declare that there is a sudden cardiac arrest,
Rest,
then
yes, sir.
and you are operating, so naturally there should be some reaction on your part also.
So definitely we call for help, sir, gather.
That is different. We will discuss that also. But first reaction,
We asked,
we are confused many a times what to do. When we are trying to hide the things, many a times it may happen. But so how to tackle, we are going to discuss.
Madam, senior person, can
Yes,
you just
yes, madam.
enlighten?
yeah, first of all, I have to keep my nerves strong. That what has happened, and a little bit I will like to know whether the pre-anesthetist checkup and
That we will discuss. First reactions, say for example, as soon as you came to know that there is sudden cardiac arrest.
yes,
Or some-
definitely. Maybe that I myself will start having palpitation, sweating. Why it had happened, and how to break the news to the relatives.
So you are panic. You are
my
panic.
Yeah.
sir, my first reaction is to the anesthetist. क्या हुआ?
Yes.
My first reaction is to the anesthetist. क्या हुआ? कैसे हुआ?
Yes.
I first blame to the anesthetist.
Yes, sir. Especially when we are
So
not
then-
anticipating
yeah.
any complication prior the surgery. When it was a smooth, single, easy-going surgery and suddenly patient goes in arrest, definitely we miss the beat. First of
We
all.
will
Yeah.
panic. We'll panic.
Yes, definitely.
Yeah. So,
And there are so many questions in our mind. How to tackle this particular situation? So this is the situation. क्या करूं? भाग जाऊं? कौन बचाएगा मुझे? There are so many questions in our mind in this type of situation. So how to manage is the discussion for today's topic. So
yes.
first rule, do not panic. Of course, it is very difficult to keep quiet in this type of situation. It is very easy to say, please do not panic, but it's not so easy. But why? Because death per se doesn't mean negligence. In eye of law, in any court of law, in any case of death during treatment, on table or during labor, etc., it is not always believed that it means negligence. And recently, in National Commission, one of our judge, Dr. Kantikar, very specifically mentioned, every death of a patient cannot on face of it be considered as a death due to medical negligence unless there is material on record to suggest to that effect. And in famous case of Jacob Matthews versus State of Punjab, which was decided in 2005, and at that time Apex Court has very clear mention that it is clear that every case where the treatment is not successful or patient dies during surgery, it cannot be automatically assumed that medical professional was negligent. So death per se is no negligence in any case of our treatment. So we should be very conscious for that also. Now, what will you do? There is sudden cardiac arrest. What will you do?
We will start resuscitation.
Yes, resuscitation is the first step. And very important thing, who will start resuscitation?
If anesthetist is present, then
Anesthesiologist
he will.
or yourself?
If anesthetist is present, then he will first do.
So first step is resuscitation. Who will lead? Who will lead the case, madam?
Naturally, anesthesiologist.
Anesthetist,
If anesthesiologist, say for example, if it is a case of normal delivery, and anesthesiologist is not there, you are
Then
only
the
there.
first person
then
who
they-
is near to that
whosoever
patient.
is available.
Yeah, first person who is
Because
near to
time
the
is very
patient.
precious thing in this type
Yes.
of situation.
I think it
Yes,
is a
Lata madam?
teamwork, resuscitation, one anesthetist, the surgeon, and even the staff all together have
Yes,
to.
it is a
handle this
teamwork,
situation.
but the leader has to be there.
Leader
if the
has to
leader
be
is
the
not there, the team
anesthetist.
will go
Yes.
here and there.
Yes,
Definitely,
rightly
definitely.
said, because before starting relax and resuscitation, I think we should call for help. Because
Yes.
we need more people getting the drugs, getting the
Yes.
instrument for certain procedure.
So it is very obvious. Surgeon is the captain of ship only if surgery goes well. But as soon as some adverse situation happens, then anesthesiologist is the captain of ship. So he is the best person. So let us see, these are some situations. Many a times in our OT, no ampule of adrenaline, no ampule of mefentin. What can we do in this type of situation? Sudden cardiac arrest, adrenaline is needed, and in emergency box, adrenaline ampule is not there.
It is not available.
In
What
a
you will do?
few of the
Yes, sir.
condition, it may happen.
I
Yes,
will ask my staff
yes.
to inform the nearest hospital which is there and ask that doctor to come to send the drug as soon as possible. And if he is sending it through his staff, I will ask the staff to come through the back door.
Would
Madam,
you,
will you give the prescription to the relatives to bring the drug?
Definitely no.
Okay.
No.
so this is the carry home, that will you give prescription to the relative? No. Never give prescription of emergency drugs to relative in this situation. Either you manage by your own staff or just mentioned by madam. You can have a phone call to nearby hospital and from there you may receive it. Next.
And if the doctor himself is coming, I will ask him to come through the front door, because then the patient party will also see that she has called someone for help, and he will bring the medicine. to
Any,
him.
if relative will go, they will come with adrenaline or any emergency drug, but they will come with receipt also. And it is very easy to prove
Yeah.
that at the time of this situation, your hospital was not having adrenaline or mefentin or steroid, whatsoever it may be. And this was real happened in case of Pune. It was intraoperative cardiac arrest, resuscitation was done, patient was in vegetative form ultimately. But when this, next, doctor had taken advice from medical legal advice, notes were perfect, documentation, everything was fine. But in this situation, she had given a prescription of battery cell of pulse oximeter to the relative. And in this situation, his argument was that my wife is in this situation because of no proper monitoring. So, merely on the prescription of cell of pulse oximeter, this case was decided against doctor, in spite of all care and caution he took at the time of emergency. So, this small thing is very important. Never give any type of this prescription in emergency or emergency drug or so to the relative of patient. Yeah, next. So,
yeah.
in big hospital there is a crash cart, but we should have a emergency tray. Drugs and IV fluid, IV set, intracath, syringe, needle, emergency injection, sticking plaster, seizures and ampule cutter and oxygen cylinder pana. Many a times oxygen cylinder pana is not available and we may be into trouble, and this laryngeal mask, etc. So, before entering in operation theatre or in labor room, we should have habit to have a look in our emergency tray, and it should be regularly checked. Check your equipments, instrument, medicine at regular interval and keep them up to date as far as regulation and emergency kits are available. So, this is one more carry home in this type of situation.
So, would you like to call for additional help? I think Madam
Yes,
already.
Madam has
Yes,
already-
she
sure.
already told that.
There should be always a low threshold for call for help. We should always call someone if you need to help. Like
Actually, in whatever setup we are working, small setup or big setup, we should have a rush team. Do you have any idea about the rush team? Can you, any one of you share that? What is the rush team?
So we should have an anesthesiologist. We should, since we are dealing with two patients, a neonatologist should also be informed, and we should have resuscitating
The rush team basically constitutes of any person who is
Yeah.
in hand,
The
who can be of
technician.
help in any
Yeah,
emergency
yes,
situation.
yeah. The nursing staff, the technicians who
Yeah.
will get the defibrillator
Sir, you
machines,
can enlighten.
everything.
So, in 2018, when I was Vice President of Foxy, it was my mission. Each and every society should have rush team. So, what is rush team? Member who is well versed with any surgical emergency, say for example, you are dealing with a case of PPH and internal iliac ligation is to be done and you are not well versed. So, you can call any member of RUS team who will be at your rescue in this type of situation. At the time of breaking bad news, at the time of mob violence, and if at all you are facing any litigation, then member of that team could be at your help. So in emergency, if you have RUS team in your society, it will be always better. So call for help. And same question, would you like to go for help? Many times, say some other place, somebody is in trouble and she will ask for help. Naturally, because many times what happens, people fear to come for help. Kaun jamele mein padega? But because whatever happened at somebody other's place, it may happen at our place also anytime. So we should be cooperative to each other. It is very important. Never hesitate to go for help. Always be ready to be helpful to our professional colleague, because balanced teamwork is always beneficial not only to the patient but to ourselves also. Because whenever you involve any other person in treatment in this type of situation, it shows your consent to save life of patient. And whenever you are facing litigation, it is always considered in court of law which efforts you put to save life of patient. So whenever you call for help, it is always in your favor.
So RUS team may consist of any surgical assistance from your colleague or near friend, for the team member who is strong enough to deal with the declaration of the bad news, to deal with the mob violence, assault, legal assistance. We know the scenario is not good in our country now. For any small thing we may be in target. So at the time of distress, maybe our head will not work in the same way. So we always need that person or some group of person to be at your help in emergency basis.
And it is very obvious, person who comes for help, he is with sound mind. You cannot take certain decision in your hospital when you are facing with your own patient. But person who is coming for help, he is very sound mind, and so whatever decision he takes will be much more fruitful in managing the situation. Yes, you want to say something?
So we have discussed regarding the RUS team, which include the medical team, the technical team. I think to control the mob violence, which is very important, especially in our country, we need to involve also the police.
We are coming to that point. So
Yes.
just now we were with, this is also very much important. Many times what happens when patient is already dead and you are closing abdomen very fast, and in a hurry you may leave mop inside, because this was happened in one of the cases, and at the time of post-mortem examination that mop was collected. So even if you are closing abdomen in a dead patient, then also very quickly search for you have not leaving anything inside, because with this small mistake may be troublesome in future if at all you are facing litigation. Yes, yes. So patient party is always free to name anybody, but at the time of proceeding of case, it is considered by court he had been or she had been to help the person. So he is not the person who was operating first. So he is not taken into that way. And there is Samaritan law. Of course, it is not in India, it is in foreign country. But in India, whenever you have come for help, it is taken into consideration by court. If you have not done palpably wrong, if as an assistant also, if you have done palpably wrong, then you could be in a trouble. But usually, whenever one is called for help, usually in court of law, there is not issue. But I can share one example of Revari only, and our own Mitra Saxena, she was here only. So in this type of one case, it was severe PPH, and she was called for help, and ultimately, in spite of all their efforts, they couldn't control PPH, and ultimately hysterectomy was done. So when post-operative, all the counseling was done with patient and patient party, ultimately case was filed, and party preferred to make a party not the first person but do Mitra Saxena. And of course Mitra was out of problem from this case, but in this type of situation many a times it may happen. But if you can prove in court of law you had been for help and primary surgeon was somebody else, then usually you could be out of problem. Nothing to worry. But always go for help. Yes, madam.
2 days back, one patient had injection and one injection in hospital, Sadar Hospital. Patient lied down and she died. She was put for NP, but she couldn't get any anesthesia.
No, but the medicine was prescribed by doctor or it was over the counter medicine?
No, doctor has given misoprostol tablet
Ah.
for cervical artery, and one injection, one time was given, nothing else. Nothing was given, the patient lie down and she died.
So there could be anaphylactic reaction of any medicine. So in any situation, whenever you are facing this type of problem, anaphylactic reaction. So in this type of situation in court of law, you will have to face certain questions. One, was it preventable? And usually you cannot say no. So one more question will come, what did you do to prevent it? Or one more question, why you couldn't prevent it? One more question, did you diagnose the problem in time? And did you manage case way in which any prudent gynecologist would have managed? If you can answer all those questions, then in spite of this situation, you are out of medical legal problem. But you should be in a position to prove in court of law, whatever you did to save life of patient, it was as per standard medical norms. And whenever this type of situation happen, anaphylactic reaction or so, what any other prudent gynecologist would have done in that type of given situation, if you have dealt with like that, then you are out of problem. But burden of proof again on your shoulder to prove that how you manage the case.
Yes. So, yeah, so next thing, what about any idea about when you sense that there is trouble and you may need to shift the patient to a tertiary care center? Have you faced that situation? Obviously, you would have faced that situation. How do we deal with it? Who goes to the tertiary center? Do you send somebody of your team? Do you yourself go there? How do you deal with that?
So naturally, two conditions: shifting the patient to higher center. One, before death, after death. So first question, after death, many times so many of our friends advise better shift patient to another center, make a show of resuscitation, and then declare. So our question is, would you entertain this type of situation to shift patient to another center and then declare death, or would you like to declare at your own center only? This is the question.
Depends upon the condition. If there is a mob, then I refer the patient.
But if it is mob, you can involve police before declaring. You can call your professional colleague for help. You can inform police that there is a possibility of some mob violence or so. So, but to declare death at your hospital when it has happened at your hospital, or would you like to shift to another center making a show patient is serious and some emergency treatment is required at higher center? So question is, what is better?
I prefer when patient comes from outside, I refer the patient. बगल में सदर हॉस्पिटल ले चले जाइए, वहाँ पे patient ठीक नहीं है, बचने वाली नहीं है. I usually refer the patient.
Anybody?
Working in a tertiary care hospital, so we
After
get
this,
this. I'm working in tertiary care hospital referral center, so we get this type of cases from the this CHCs or PHCs that the patient has already death and with their sending, so with resuscitation. So we have seen these scenarios, but sir, it's relevant to declare the death at the center. If in most death on table, 90% of cases the resuscitation can be done. So if the resuscitation can be done with the crash trolley, we can shift the patient with the doctor from our side, even the surgeon who is available can shift to the tertiary care center, if it is possible, sir.
Question is very clear. Patient is already dead.
Then sir, we should declare at our center,
You
sir.
know, nothing can be done now.
I will declare at
Even
my
then,
center.
Even then, would you like to shift patient to make
No,
a show?
sir, I will declare at my center with the help of any of my senior and colleagues and the gather help with security and any police information. I will declare at my
so
center.
you will declare in your, madam, anything to differ?
I refer the patient because they start crying. इतने सारे लोग जमा होने लगते हैं. मेरे patient बहुत serious है, बगल में hospital ले लेके जाइए वहीं पे. Most of the time I refer.
Morally, actually, morally after death we
Mike,
should.
Mike, नजदीक रखिए.
Morally after death we should not, because they are also saying that even if with ventilator also that the patient is dead. Morally we should not.
अरे morally नहीं, मैं तो
but
पूछता हूँ कि
yeah,
legally, चलो legally, not morally. Morally you are bound to declare agreed, but legally, if you have not declared and you have sent patient to some other hospital and then dead body is received there and they will declare you brought this patient dead. So in this type of situation, it will be very difficult for you also to justify of your action. Yes, ma'am.
So, suppose we send a patient with some paperwork, and what if the patient goes there and
Like what
they
paperwork?
uh,
The patient is
so
dead.
when, in the sense, what treatment you gave, you've done the resuscitation, the patient is, at the back of your mind, you know the patient is dead, but to show off to the
So you will
patient's
shift the
relative,
dead patient to somewhere else with the
I
referral?
would not. I would like to declare at my place, because then I'm
So-
prepared to handle the questions of the relatives.
So let me share this experience. This is a real happened case in city of Pune only. Our own gynecologist, whose his medical officer was on duty, and 27 years old boy was brought to the hospital in a dead condition. So as soon as he declared that he is no more, he is already dead, then there was a mob of almost 100 people and ransacking of hospital and lot many. So with this experience with this experience, that fellow decided that in this type of situation, it is always better to ship patient to another center. And you won't believe, in the same hospital with same person, one more patient was brought in a dead condition, and he told nothing can be done here, she is very serious, better you take patient to another higher center, and patient was brought to that higher center. That hospital received dead body because he was already dead, and now problem came, who will issue death certificate? Post-mortem examination is to be done or not? So there are so many questions in this type of situation next. So it is easier to fight a case of negligence rather than case of forgery, because whenever you try to make this type of show, it becomes a case of forgery, and it is a non-billable offense. So it is always faced negligence, it is billable offense, and forgery is not billable offense. So declare death your hospital only, of course with protection, with police protection, with your friends, but never try to make a show that patient is serious and we have referred patient to higher center. If he is already dead and nothing can be done in this time. Of course, if patient is serious or still patient is living, then it's a different story. Now we are coming to that discussion. Yes, before death.
Before death.
So if patient is serious, or say for example patient suffered cardiac arrest, you resuscitated and heart is fine. Now in this type of situation, would you like to refer patient to higher center? Again it is a double-edged decision. If too early, why did you not resuscitate and send? And next. And if it is too late, why did you not send early? Because this is very tricky situation whenever you refer any patient to higher center. So in this type of situation, what will you do? You will have to justify yourself in court of law that whatever you do it was in good faith of patient. So take collective decision which could be justified in court of law. There should be quick discussion with patient party as well as other person who have involved in the treatment part. So this should be the, and when to shift.
When to shift, yeah.
When to shift, because avoid shifting hemodynamically unstable patient, because she may die on the way to the hospital. So at least you try to stabilize the patient, and meanwhile you explain everything to the relative, and then shifting patient would be much better. Who will decide where patient is to be shifted or patient is to be referred? Who will decide?
Madam,
Anybody can tell.
anybody can tell.
You will decide, you will discuss with patient party, with your other colleague, where patient is to be shifted.
So I will call for help. If my senior doctor is available nearby, then definitely we'll together we'll take the decision to shift the patient to the nearest hospital where the resuscitation facility or ICU facility is available.
So you will take the decision alone, or we?
I can take alone if I see
Along
the
with
patient
the
is stable, and even if
patient
my
party,
senior
along with the
Not with the
patient
patient
party.
party.
Yes.
Along with
Discussion
the
with the
patient
patient
So
party.
along with the ultimate decision would be on part of patient party only. So they may have a choice to take patient to government hospital, trust hospital, private hospital or medical college hospital. But we can give him inputs, okay, which hospital is best in this type of situation. But ultimate decision would be on part of patient party. this is also very important. Whenever you shift any patient giving any paper, then take a signature. If patient is in a position to sign, fine. Otherwise, husband or any relative or witnesses with date and time when patient left your hospital for further treatment is very much important. Escort of patient. Who will escort patient?
Will you send them alone with the relatives?
It's better one doctor should escort the
Yes.
patient. It's better. But in my opinion, the treating doctor should not escort.
And it is also very important in the same ambulance with all this emergency
same
drug,
ambulance.
oxygen cylinder, because again it happened in city of Pune only. Doctor escorted the patient, but doctor was in his own car, and during transit, patient suffered some cardiac arrest and patient couldn't be saved, and only he was in his own car when he is against at the time of deciding the case, and case was decided against doctor. So whenever you escort any patient in this type of situation, always you should be in the same ambulance. It is very much required by law also. Yes, next.
So, as we were discussing, who will accompany the patient?
If treating doctor is busy,
If the treating doctor is busy.
you are busy with some other emergency, in this type of situation, what will you do?
A trained staff. My trained staff.
Anesthesiologist भी जा सकता है सबसे अच्छा तो
If any
anesthesiologist
other
रहेगा।
doctor or anesthesiologist is the best person in
Best
this
person.
situation. So if any other anesthesiologist available, he can accompany the patient.
May I can
Yeah,
send
yes,
to the
madam.
minister.
Why? No, no, no. Our experience is totally different. When they are paid for that, they will of course go.
Yeah,
No,
with us it is different.
No, they will not go in Bengal also.
Because in court of law, I was exhausted doesn't stand in court of law. Whenever there is a question of life and death of somebody, then you cannot be simply excused.
We are usually sending trained staffs. Usually. Sometimes doctors are also going. Sometimes. Usually staff.
Staff
we
can
send
go,
our
equally trained staff can go,
Trained staff.
senior staff, MBBS doctor can go, the RMO can go. Yeah.
So any doctor can accompany the patient. If no doctor is available, at least trained staff. But patient should not be sent alone. So this should be the carry on.
Usually we send with trained staff.
Next.
And before sending the patient, we should inform the hospital in which we are sending
We
the
are
patient.
coming to death also. So use of pneumatic anti-shock garment because it saves time, and other precaution, just availability of bed, operation theatre, instrument like ventilator with right and proper person. Because when patient reaches there and ventilator is not available and patient is in need of ventilator, and to shift patient from that hospital to another hospital will time is very precious in this type of situation. So always confirm of availability of bed, oxygen cylinder, ventilator, etc. And very important is transport document. So whenever you refer any patient in this type of situation, you will have to give all the transport document to the patient. So you have not to remember this, you have to simply visit Foxy website, and there Foxy uniform consent is available. With three medical legal experts, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad, we have prepared almost 30 different consent. Say for example, cesarean section, hysterectomy, abdominal, vaginal endoscopy, termination of pregnancy, medical method, surgical method, cervical encerclage, and in the same list, we have prepared consent for this also. When you are referring patient to higher center, which kind of document you are required to give to the patient, it is a prescribed form. It is a prescribed form. So name of patient, date and time of referral, region for reference. So we are not going to detail. So everything is available on Foxy website. You can download all those consent and you can use in your day-to-day practice. Next. So confirm with proper person, and all the document whichever you are handing over to the patient party, take a signature in your original copy. So at the time of facing litigation, you can prove that all the documents were given to the patient. Next. Handing over patient to the proper person where you are referring the patient. Next.
So once you refer to the concerned place, make sure you hand over the patient to the concerned doctor preferably.
And take a signature
And take
in
a
your
signature.
original copy with the date and time. So when patient left your hospital and when patient was received by center where you have referred the patient. Next.
And obviously we have to complete the paperwork, because paperwork is ultimately what is going to be important in the court of the law. And mention all the notes of the resuscitation process also. Yeah.
Naturally, good record, good defense, poor record, poor defense, no record is no defense. And it is my experience during my medical legal practice. We doctors are very poor, because whenever we take any file of any our professional colleague, and due to this poor record keeping, it becomes very difficult for us also to face in court of law.
And up to date record, what was done, nothing was neglected, and whether the treatment actually met the standards. We have to mention all those things, what we have actually done in the OT, and which is easily accepted when offered in the court of the law. Now, record should also include important bills, like your hospital bills. If you are, you have done the case in your own hospital, the bills of oxygen cylinder, whether the cylinder was refilled, that receipt, defibrillator bill, ventilator bill, when it was purchased, all those things, servicing dates, because somebody may accuse you regarding that your particular machine was not working, that's why the patient has expired.
So, bill of refilling of oxygen cylinder is very important document, because in one of the cases which happened in Gujarat, allegation was when patient suffered heart attack, oxygen cylinder were empty, and we could be saved in that very case. We produce all the bill of refilling of oxygen cylinder 1 day prior when this accident happened of cardiac arrest, and 1 day prior all the cylinder of oxygen were filled up, and with this simple bill in court of law it was considered that oxygen cylinder were not empty at the time of when patient suffered a heart attack. So this simple thing is very much important to keep in mind.
Even the
So
expiry date of the emergency drugs
Yes.
has to be very much.
So now we have no time, otherwise how to declare bad news. This is also one very important.
No, so we can finish this. This is important. Yeah. No, we have 1 minute.
If you all allow, then we can have a working, yes? Okay, I got it. So 2 o'clock, yes sir, 2 o'clock we have new speaker who will be coming in. So we'll use next 10 minutes to, get the discussion.
How much time do we have?
9 minutes now, please.
Fine. So now very important topic in this type of situation, declaration of bad news. How you will declare? Bad news.
Bad news.
And in this type of situation, it is bad news also. BAD or BED.
So, madam, would you like to discuss this with your staff before declaring to the relatives?
Yes, definitely.
Yeah, what are you
Always
worried?
yes.
What you are worried about?
They have to give same statements.
Yes.
They should know
So
what
it can
is
happen in scenarios that sometimes your staff goes outside. Somebody kya hua? She doesn't know what to tell. She tells, अरे कुछ ऐसा डॉक्टर ट्राई कर रहे थे, दवाई नहीं था, खत्म हो गया.
No
बस.
या तो
statement should be given
ये-
by
ये-
junior
ऐसा
staff.
सवाल आएगा ना, ये आपके कोई भी स्टाफ बाहर जाए, मौसी अंदर क्या हुआ, और डॉक्टर वाज ट्राइंग लेवल बेस, बट एक कोई नस आर्टरी कट गई और फिर ब्लीडिंग हुआ. Many a times it becomes a very troublesome in future then to face. So we will have to, we should have a discussion with our staff, what happened, why happened, what we did, and it should be in the same synchrony with all the staff. So whenever any staff is asked by any relative, then it should be communication with relative is very important. Once we have a word with our own staff, and now we have to declare with relative. How you will declare? Alone, or would you like to involve your professional colleague?
Yes, I will like to call our senior colleague. Then he should be aware of all the facts in sequence. he should review it as soon as possible, and he should stand by to, he's the right person to communicate after knowing all the facts with the relatives, with sympathy and showing all concerns. But the communication should be in an honest way and in a transparent way, but avoiding the medical jargon. And we should be alert that the communication that the person is doing should be done by everyone, and any junior staff should not be allowed to communicate anything.
Okay.
So you are protected in this type of situation when somebody is with you. Would you face or run away? Many a time this is very important question. Okay,
We
there is
face.
a sudden death in hospital.
We face.
Face.
Yes.
Even if you are in danger of life, then also would you like to face?
No.
Depends upon the situation.
Depends upon, if at all it happens, it is always better to run away. But where? To police station, not anywhere else. Because once you go to police station, this has happened and my life was in danger, so I have come here. And that all the things will be taken care by police. Because once you go to police station, you are not going to hide anything. It will be consent in court of law, whenever you are facing in court of law.
So never even think of running away unless the situation is out of hand. So
Now, this is very important thing just mentioned by, who will declare? Your team. So you are head of the team. Would you like to declare by yourself, or would you hand over to your junior to declare?
The senior person should declare.
So main chair belongs to honor or not senior person. Communication is his job. मानो कि दूसरे लोग साथ में आए हैं मदद के लिए लेकिन you will declare yourself. They may be helpful to you in a communication, but main role is your main head of the team.
एक बार में डिक्लेयर नहीं करना चाहिए, धीरे धीरे करना चाहिए. सडन डेथ हो तो भी पहले जाके सीरियस सब लोग कोशिश कर रहे हैं,
two situation. If you are dealing with a high risk patient, madam, if you are dealing with a high risk patient, then you should inform patient and patient party time by time. So this is the situation. This is
priming should be done from before.
जैसे यूट्रस प्राइम करते हैं ना, हम रिलेटिव को प्राइम करते हैं to face this situation.
So I mean, we need to get the patient relative in confidence, especially while doing intraoperative complication अगर आए, I think we need to explain that time. That is the time actually
Yes.
कि we are resuscitating the patient. Patient is serious. We are doing this, that, so they get the confidence. They get aware about the fact. And later it is easier.
In Hindi film, हम आपकी पत्नी को बचा नहीं सके ऐसे कह के हीरो आ जाता है बाहर. तो in our day-to-day practice, it is not so simple. So next. So it is very informed condition from time to time. If you are dealing with any serious condition, be by senior most person only and not by junior. Face together with rush team if available. Be polite, sympathetic but assertive. Be prepared for knee-jerk hostile reaction because you never know what could be the reaction on part of relative at the time of this. Be prepared for mob frenzy. Do not lose patience. There are so many questions on part of patient party. And same question, one more relative enter in the room and again same question will be asked. So do not lose patience and do not blame each other. When more than one person is involved in the treatment, do not blame each other. And this is very important. Making statements that might be construed as an admission of fault on your part, always to be avoided. Never say it was my mistake, by mistake it has happened. We tried our level best, whatever happened, it's bad luck on part of you as well as us. That way we should communicate. Very important point, death certificate. So in this type of situation, naturally relative ask for death certificate. Would you like to give death certificate or would you like to submit patient for post-mortem examination? Anybody
Post-mortem should be offered. Should be offered. Post-mortem examination should be offered.
Post-mortem should be offered from your end.
Death certificate is issued
From our
by
end,
municipality or panchayat bhavan. We can only write dead body carrying certificate, time of death, cause of death, and other things.
In
Postmortem
sudden death,
examination
postmortem
is
must be done.
in the
There
jurisdiction
are
of
two
body.
situations. Let me put this way. If you are sure of cause of death, say for example atonic PPH, hypovolemic shock, and in spite of all your efforts patient expired, even then would you like to subject patient for postmortem examination?
Sir, it's
or would you like to give?
So it's a legal duty of a doctor. If the cause is
better-
known,
it's
then we
better
should
to
give the death certificate.
patient.
If the cause is not known and that is unexpected or unawareness of the cause of death, then we should subject for postmortem, and then we'll inform the police, and accordingly, at that time we shouldn't give the death certificate if the cause is not known of death.
Many a times relative are ready to give in writing. We do not want to go for postmortem examination. Would you like to entertain this? If
So
at all
we'll
you-
inform
you-
police, sir, and then.
We inform police, then there is a job of police then after
Yes,
to
sir.
how to manage to go for postmortem examination. Because in court of law, even this type of writing has no legal immunity. It doesn't stand in court of law. So,
Even if
whenever
they
you
say
feel
no, you have to
that
push
postmortem
for TM.
examination
Yeah.
is necessary, you inform police, and police will take over all the charge to go for examination also. Yes, next.
Yeah. So police involvement, I think we have, are you clear on that? Should
Yes,
we
we
involve
should.
them?
Yes,
Yes,
sir.
you should involve them, yes. So call them if any problem is suspected, if at all. Now very important portion, should we know the
Many a time
section of
what
the
happens
arrest?
in this type of situation, relative will rush to police station and they will demand you arrest doctor. And many times it may happen also, police may arrest doctor. So in this type of situation, would you like to know the section of arrest? In which kind of section police may arrest you, etc. So let us have a discussion for that also. Anybody can. Last minute. So
300.
let me conclude by this. In famous case of Jacob Matthews, it was discussed at length in which kind of situation doctor can be arrested. And Jacob Matthews case, Supreme Court came with 3 guidelines. Next. Guideline number 1. Private complaint may not be entertained unless the complainant has produced prima facie evidence before court in form of credible opinion given by another competent doctor to support charge of rashness or negligence against accused doctor. So this was the first guideline given by Supreme Court, because police is not expert to decide. Number 2, number 2, that very opinion should be from non-biased person, so preferably from government hospital. So investigating officer will collect all the paper of treatment given. He may take statement of patient relative, staff, and all paper will be sent to nearby medical college, hospital, respective department. And if there is a prima facie evidence or opinion from medical college, hospital that it seems to be prima facie negligence, then only investigation may be initiated and doctor can be arrested. And in this case also, one more case, Martin D'Souza, in this case also, very specifically by Justice Kaju, law is watchdog and not bloodhound. If reasonable care is taken, doctor will not be held negligent, so doctor need not to worry. And Bolam test, that is how you have taken care during the treatment, is considered in court of law. And court are not expert of medical science, so they will be dependent to medical board's opinion or any other opinion. So this is very clear as far as this Supreme Court's judgment is concerned. Okay.
Okay.
So very quickly, only few seconds only, how to prevent and sorry. So what to do and how to prevent? There is always a way. Final word from each panelist. Carry home message. Yes, madam. From you. What would you like to say to the audience with carry home message with this panel?
Yes, absolutely. I mean, the topic of panel today was like a very important cheese, especially as far as medico-legal issue is concerned.
Ma'am,
So-
one word you put, one or
Only
two
one
words.
word. And
Yeah. So go slow.
quickly
go
we have to
slow,
wind up.
Avoid accident.
Go slow.
Yeah.
Okay.
Go slow.
Okay.
Avoid
Next.
accident.
Next, madam.
And
Please.
yeah.
Whenever this happens, be sympathetic with the attendants.
Pertinent topic to discuss and deal with, and through this talk we have learned a lot about how to deal with this medical legal issues.
Yeah.
I think every clinician, every doctor should have a basic knowledge of the legal
Basic
system.
knowledge is essential.
Legal system, and they should be prepared. Nobody wants to face such kind of situation, but they should be prepared for the worst.
Always
Lat-
take
Lata ma'am.
help. Always take help from others.
Yes, ma'am.
In such-
I think that teamwork is the best thing for giving mental and both professional help, both.
Be honest and proper documentation should be there.
First of all, I will pray every day and before entering into the OT that God do not allow me to face this situation, and regular training of my staffs, regular drills, like if the patient is having this problem, staff should be trained, and every day emergency box is to be checked by the doctor also, whether the oxygen cylinders are full or not, whether the emergency drugs are there or not. And another very important thing that today Sadhna madam also told, that by mistake, if tranexamic
So,
acid is injected intrathecally, it is very, very fatal. So, staff training, and every day I will pray God that this
So
should not
these
happen.
gentlemen have so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have, if you do not know how to use them, they will never be enough. So, next, have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. Very quickly. Very quickly. So medicine is science of uncertainty and art of probability. The problem with world is that intelligent people are full of doubts while stupid ones are full of confidence. And so Albert Einstein have very nicely said, only two things are infinite, the universe and human stupidity. And I am not so sure about former. So wish you and me too all the best. God bless you. Have a litigation-free medical practice with regard. And I always conclude my talk with this slide. If you want to sleep like this, take tender care of your patient and comply with the provision of law. Pray your Almighty God before going to sleep and keep my visiting card below your pillow. So salute to all. Thank you very much. Please do not assume, please ask any question if time permits or organizers permit. Thank you very much. And thanks for giving some more time.
Check. All right, everyone, sit back because we're gonna get started with 2 p.m. session. It's going to be a video lecture. We got 3 speakers with interesting videos, and they're gonna share a lot of knowledge with us. Everyone, please settle down. All right, with respect, I'm going to invite the next chairperson on dais. All right, may I please request Dr. Preeti Balasahai to please come forward as the chairperson, Dr. Vibha Jha and Dr. Sujata Chaudhary. Dr. Preeti Balasahai, Dr. Vibha Jha and Dr. Sujata Chaudhary. have a working lunch, ma'am.
Hello. 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 Good afternoon, everyone. First of all, I must give thanks to the organizing team for giving me the opportunity to share this important session. And the first speaker, I will.
Excuse me. First, you introduce the chairperson, at least. Oh, you have it. Everybody is, they don't listen. Okay. Very good afternoon to all, and welcome all of you in this a very interesting and informative session. That is the surgical management of PPH. It is a video session. I am Dr. Professor Priti Saha, ex-HOD, Department of Gynae, RIMS, Ranchi, and I am very much thankful to organizing persons who has given me this opportunity, invited me. Thank you especially Dr. Alka, Dr. Niba, and all the organizers. I was in PMCH, everybody knows me, so nothing to say more. Thank you very much. Now I call.
Hello, I'm Dr. Sujata, and I want to call the first speaker, that is Dr. Sangam Jha, additional professor from AIMS Patna. She's going to speak on uterine compression sutures. Dr. Sangam, please.
Thank you, ma'am, for introduction. A very good afternoon to all of you. So my session is on uterine compression sutures. It's not working. It's not working. Slide is not moving. Postpartum hemorrhage can complicate around 2 to 4% of vaginal delivery and 6% of the cesarean section. It is one of the leading cause of maternal death. As per the WHO statistics, it can account for 60% of maternal death. So, it is important for all the obstetricians that they should be well versed with all the treatments available for the management of PPH. So we all know that what are the causes of postpartum hemorrhage. That is 40. There could be problem in the tone. There could be retained product, trauma of the genital tract, and finally problem in the coagulation. So this is an algorithm for the management approach in cases of PPH. The initial management is to use uterotonics, uterine massage, bimanual compression, and use of intrauterine tamponade. When these initial management fails to achieve hemostasis, the next step is to use relatively invasive procedures like vessel embolization, vessel ligation, uterine compression sutures, and hysterectomy. So I'll be discussing the different types of uterine compression sutures. So these are the sutures applied externally on the body of uterus to act as a brace to facilitate uterine contraction and function in a manner similar to the manual compressions. So according to this Young-Laplace relationship, the force is the compressive force acting on the uterine vessel is directly proportional to the wall tension generated by the uterine contraction and inversely proportional to the radius of the uterus. So when force acting on the vessel cannot be high if the radius of the uterus is large. Most commonly, it is used for the management of atonic PPH. However, it can be used in cases of placenta previa, placenta accreta, or sometimes in the prophylaxis against the recurrence for the treatment of chronic uterine inversion. So in 1997, Dr. Christopher Bay-Lynch has pioneered the use of compression sutures in atonic PPH. Since then, many modifications have been developed, and these are the uterine compression sutures till date. So I will be discussing the more common which are used in day-to-day practice by the obstetrician. So first is the Bay-Lynch suture. It was developed by Christopher Bay-Lynch. This is a pictorial representation of the course of the needle passes through the uterus and uterine cavity while performing this Bay-Lynch suture. This alphabet indicates the sequence of needle course while doing the Bay-Lynch. So the first bite is taken at the right edge of the lower edge of the hysterotomy incision, or approximately 3 centimeter from the edge, and the second point is coming through the upper edge of the incision. Then it loops over the fundus and enters to the uterine cavity from the posterior wall, and again loops back to the through uterine cavity to the posterior myometrium. And this passage over the fundus, and again it will pass through the upper edge and the lower edge of the hysterotomy incision. And finally, suture is tightened in the lower segment. And finally, hysterotomy incision is closed. So initial report by Bay-Lynch, they have achieved 100% success in achieving hemostasis in this case. However, there were certain concerns like it require hysterotomy and it do not transfixes both anterior and posterior wall of the uterus. Second is the Heman sutures. This is again pictorial representation and showing the course of needle it will pass through. It doesn't require hysterotomy. Here needle transfixes the anterior uterine wall in the lower segment from anterior to posterior. Care should be taken to retract the bowel appropriately so that it do not injure the intestine. Then a loop is passed over the fundus and the knot will be tied at the fundus. The same procedure will be repeated on the other side. and the suture is being tied over the fundus. You all can appreciate that at the time of tying, the assistant should compress the uterus so that sutures get tightened correctly and adequately. So same is being repeated on the other side also. However, it has been noted that this suture can slide in or slide off, that is a displacement of the suture lateral side or medial side when there is an involution of the uterus occurs. So to avoid this, we can take a few transfixing sutures also. So this is a transfixing sutures which will fixes the longitudinal suture, that will prevent the sliding off of the longitudinal suture. So in my practice, I used to take 4 such sutures, 2 anterior and 2 posterior. So there are few demerits with this, that there is a risk of uneven pressure amongst the independent sutures and risk of unidentified obstruction of the cervical os because it is taken blindly through the lower uterine segment. Third is the choice square sutures. This is a pictorial representation and the alphabet indicates the needle entry point and exit point. So needle transfixes the anterior abdominal wall and the posterior abdominal wall. It comes out through this. That is this is actually the B point. The suture will come out through the anterior myometrium, and then again it will enter through the point C from anterior to posterior myometrium in a square manner. Actually, it should be done with a straight needle, but when it's not available in the emergency, a simple suture needle can be straightened. Although it's a little bit difficult because the length of the needle will be smaller than the width of the uterus. So always during tying, assistant should compress the uterine wall for the adequate tightening. Such 4 or 5 square sutures can be taken in case of atonic PPH. If there is a bleeding from the lower uterine segment, that can also be taken. So this is final picture when you have taken a 3-4 squares. However, there is a most common demerit that as there is a multiple needle puncture sites, it can result in increased bleeding, and the suture material is more, so that can potentially increase the risk of infection and intrauterine adhesions. This is a Pereira sutures. Here it actually takes us 2 to 3 circular transverse sutures, and it is also known as non-penetrating suture as it not entering into the uterine cavity, and these transverse sutures are fixed with the longitudinal sutures. This video will demonstrate how we perform this. So with the needle penetrates only the serosa and the superficial myometrium without penetrating the uterine wall. And author advocated that as it is not piercing the uterine cavity, it will decrease the risk of infection and intrauterine adhesion formation. Secondly, we are taking multiple sutures, so it compresses the uterine cavity evenly. So this is how it is tied. 2 to 3 transverse sutures are taken. As time is less, I'll show how to take a longitudinal sutures in this case. So after this is the second transverse suture. Here the longitudinal suture starts with the transfixing and tying a knot at the dorsal end of the lowermost transverse suture. Then it fixes with the other transverse suture and finally loops over the fundus, and anteriorly the suture will end at the lowermost transverse suture by tying a knot. So this longitudinal suture will compress the uterus and it will help in the even compression, so that there is no space left inside the uterine cavity, and that will decrease the bleeding. So at least they have advised at least 3 transverse circular and 2 longitudinal sutures should be taken. However, it seems that it takes more time compared to other compression sutures. And second, it's not widely used, maybe because it's time consuming. This is a Masubara Yano sutures. Here 2 longitudinal sutures are taken, and these longitudinal sutures are fixed with the 2 transverse sutures. So needle transfixes the anterior and posterior uterine wall. And then again transfixes from the posterior uterine wall to the anterior uterine wall.
Hello.
And it is tied at the fundus. So same is repeated on the other side. Sorry. So same. This is important, that how you take the transverse suture. The needle should penetrate lateral to the longitudinal sutures. Right, it's not playing there. And this is the final picture how it looks like. This can be used in case of chronic, to prevent the recurrence in case of chronic inversion also. So this table has been taken from this study which was published in 2013, although we do not have any randomized control trial or any long studies on the sutures. So this review has taken all the original articles and compared the outcome and the hemostasis and the pregnancy outcome, and they found that almost all the sutures have achieved almost 76 to 100% of hemostasis in 100% of the cases. The pregnancy outcome was also good, ranging from 11 to 75%. So this study has looked into the influence of needle and suture type for the uterine compression suture, and they have found that 80% of cases were treated by catgut and Vicryl, and they could not find out that which suture would be better for uterine compression suture. So whatever available in the OT can be used except the non-absorbable sutures. The most common post-operative complications reported till date are hematometra, pyometra, intrauterine adhesions, localized areas of uterine necrosis and full thickness defect in the lower uterine segment or fundus, and intra-abdominal adhesions. So as we do not have any randomized control trial, we do not know the exact figure of these complications, and so the choice of sutures will depend on the convenience and expertise of the obstetrician. Fertility outcome, this study has looked into the fertility outcome in the women who had undergone the uterine compression suture, and they found that 91.5% resumed normal menses within 6 months, and 85% had who had desired for fertility became pregnant subsequently. So take home message is that uterine compression sutures achieve good hemostasis without grave complication. Uterine compression sutures preserve future fertility. Chromic catgut, vicryl or monocryl number 1 or number 2 straight needle or curved needle can be used for performing these procedures. And most important, that every obstetrician should be proficient with the placement of at least one uterine compression sutures in case of atonic PPH.
Okay.
Thank you, ma'am.
Thank you, Dr. Sangam. Nicely related about all the compression sutures like B-Lynch, core, but in the general or the practitioner, they are doing mostly the B-Lynch suture and the core suture. B-Lynch suture is nice, but there are some side effects like you have mentioned, Asselman syndrome, and there is a necrosis sometimes also. This is the very one of the important that Dr. Bhaskar was saying in his lecture, that it is one of the side effects. Post-operative adhesions is mostly, and we don't know about the fertility outcome because it's not the follow-up is very poor, or sometimes it is a failure. So thank you, Dr. Sangam. The time is very less. Now,
Thank you, ma'am.
thank you.
Thank you.
Thank you. Now the second speaker is Dr. Okay. This is her CB, Dr. Mitra Saxena. She is very popular, and I think you will like her talk. This is the all that devascularization sutures, one of the very important. Okay, Dr. Mitra.
A very good afternoon to all of you. Thank you for being here in this important session, despite very interesting talks going on in the other hall. Thank you, chairpersons, and thank you to Dr. Alka Pandey, team of Labourcon, for including a very important practical session for Labourcon. So my predecessor has very beautifully summarized the compression sutures, and I bring you greetings from Rewari. A lot of people call it Revdi. So I just want that should be clear. I'm going to be talking about uterine devascularization. Actually, all of us know that the biggest bugbear in an obstetrician's life is PPH, and because it is the quickest of killers. So all of us have to be really proficient. This is a very favorite slide of mine, which says from prevention to management of PPH, and all these things, having ruled out trauma, used uterotonics as a second line, and temporizing all those balloon tamponades and packing, etc. And then we have the role of compression sutures, stepwise devascularization, internal iliac and obstetric hysterectomy. These are all the gadgetry we have. This is the armamentarium in our, knowledge and our skills. And the best and the most important thing is to know what to do when. The first step is how to do it. Beautifully, Dr. Sangam has elaborated how to do the compression sutures. But which case you are going to take the decision कि इसमें तो मैंने compression लगाना है या इसमें मैंने stepwise devascularization करना है. So, friends, of course, every one of you are very familiar with the anatomy and the blood supply of uterus, and we all know. But what in my presentation, I'll be showing you some videos, and more importantly, I love to show diagrams, because when we were studying anatomy, we were very proficient, but now we forget. But the most beautiful diagram where we know how the uterine artery ascends and descends, supplying the upper segment and the lower segment, anastomosis with the ovarian artery, which is a direct branch of the aorta, and at the level of tubes and ovaries, there is this beautiful anastomosis. So basically we have to understand how efficient God has been in supplying good blood supply to the uterus for the process of pregnancy and nurturing the baby. But as obstetricians we have to be very well versed in how to save the patient, save the uterus and save ourselves. So when we talk of stepwise devascularization, I think all of us know it is to squeeze the blood supply of the uterus. So the most important thing, the uterine arteries of the side which is affected or of both sides, then go below, take additional suture and then ligate the utero-ovarian artery. So this is 5 steps, but very important is always to respect our neighbor, the ureter, and consider something, I want to, okay, I'm not going to be discussing the anatomy because only this diagram on the extreme right, this is very important because we have to understand that the whole uterus, cervix, lower segment, vagina, everything is involved in the process of labor, and the important vessels are the uterine, the ascending and the descending, the vaginal branch, and also the internal pudendal. Why I am saying is that when we are dealing with PPH, which could be traumatic, atonic, we have to respect all the pelvic vasculature, and we have to make sure that, of course, this is another very beautiful diagram, which we all should always remember, even in our sleep. And this is the common iliac, this is the posterior division, and this is the anterior division. So internal iliac is the main blood supply of the pelvis. So none of us can forget how it is placed in the pelvis and how we have to, the idea is only to understand that whenever we are ligating both vessels of both the sides, it's not that we are decreasing, total blood supply is not shut off, it's only that the pulse pressure is decreased. So whether it is the bilateral uterine or it is bilateral anterior division of internal iliac, the mechanism of action is the same. That is, the arterial circulation is converted into low pressure venous system, and that gives time for the clotting and the processes of recovery of clot formation, etc. So these are some very important diagrams which I always show whenever I am dealing with internal iliac. And now this, before I go into the details of the procedure, I want to just stress this part, which is very important, that the uterovaginal blood supply, the S1 and S2 segment concept. So what is very important to understand, that the blood supply of the upper segment and the lower segment is now very well demarcated into the S1 and the S2. What is important is that the S1 segment comprises of the upper part, and that supplies, the uterine artery supplies the body of the uterus. And the S2 segment, which is the lower segment, cervix, upper part of vagina and parametria, supplied by the descending branch of uterine, the cervical branch, vaginal branch, and now the permutation combinations are so many that they could be branches of uterine or they could be direct branches of the anterior division of internal iliac artery. What is important is now that, in our times when we were doing obstetrics, if you knew how to do obstetric hysterectomy, it was good enough. We thought that is the only way to save patient's life. But now what is important is not just saving the patient's life, but also to save the uterus of the patient. So we have to understand that if it is, this is the diagram which everybody should look. This is the upper segment of perpendicular line drawn from the posterior aspect of the bladder. This part is the S1 segment. So whenever there is bleeding from the uterus, we have to consider the stepwise devascularization. But if the bleeding is from the lower part, S2 segment, we may actually, whenever we are dealing with wall trachea, etc., we may first actually go internal iliac ligation and then repair those tears which are bleeding torrentially. So if we know the distinction, that in which case we can actually do internal iliac first as an emergency and then go on and repair the tears, and we can save the uterus also. So having said this, this is the graphic representation of the S1 segment and the S2 segment. So idea is to turn the tap off from the top. So these are, now I would like to actually show you the video because otherwise we won't have any time. So this is a step, this is a video for stepwise devascularization. So when we have to actually ligate the uterine artery, it's very simple, it's not difficult. First step is to exteriorize the uterus and make sure that whenever we pass the needle, it is atraumatic. So after having palpated, this is on the left side, having made sure that we have deciphered the uterine artery, needle is going from anterior to posterior side. An important thing is to always include a pass of the myometrium. You don't want to just ligate the vessel because otherwise the vessel will tear off. So whether it is the uterine artery or the tubo-ovarian complex, you have to always take it from the broad ligament and taking a bite of the myometrium. You can also take from the myometrium and bring it out from the broad ligament side. It is actually depending upon what side you are operating on and how are you comfortable. You know, which movement of yours is stronger and smarter and where you can see. Everything is to be done under inspection. So again, this is on the right side. So here you will see that again, we are going from the broad ligament anteriorly to posteriorly, having made sure that this is the uterine bundle, and from anterior to posterior in the broad ligament. And then when we bring it out from the substance of the myometrium. So this is how to ligate the uterine artery bilaterally. Actually, if a vessel has avulsed only on that side, then this is to be done unilaterally. But if we are doing it for a atonic PPH, where the uterus is actually totally like a bag, and we want to shut off the blood supply of the uterus as a whole, then we have to do bilaterally. So then double ligation if we need. Actually these are, videos have been prepared by my colleague, but this is in a peacetime. So this is only for demonstration. This is not, in an actual case, but we have to, once we know the procedure in peacetime, we can always replicate it in the emergency. So just for that you can understand that we can go 2 centimeters below the first suture and ligate on both sides. And then coming to, same thing is to be repeated on the right side. Another thing is you can actually, when you're standing on the right, you go from the broad ligament for the left side and bring it out from the myometrium on the left side, and on the right side, take from the myometrium, bring it out from the broad ligament. It all depends on the ease with which you can ligate. It's not rocket science, it's very simple, and the only thing is our decision making has to be very sensible. Now coming to ligating the utero-ovarian anastomosis. So again, after exercising the uterus, we see that we have to look at the cornual junction, and we have to include part of the myometrium and make sure that our needle does not puncture any vein even. We can do it everything under vision, and you take it out from the myometrium, you go back and come in front and ligate. So basically ligating the utero-ovarian, the stepwise devascularization, that means the uterines of both sides and the utero-ovarians of both sides. This is a very helpful, but choice of case. For example, recently I had a patient who had delivered outside and there was retention of placenta, and it was adherent placenta at the fundus. And after taking out the maximum placenta, still patient was bleeding and everything was done. So what next? So the next thing that we did was that we had to open her up. We didn't have the facility to, this SR cannula or something. So what we did was we just did the stepwise devasculation, and also we put the compression sutures. But one has to understand that if it's a primary, you should not multiply the procedures because that will cause problem. If you combine stepwise devascularization with B-Lynch, the chances of Asherman is much more. So that is there, and then so we have to understand that the idea of these compression sutures and ligating the vessels was only so that we could save the uterus. Otherwise, all obstetricians were very proficient in taking out a uterus which was refusing to contract. But then now also I'll take this opportunity to mention the ligation of internal iliac artery, and as I said, with increase in cesarean sections, increasing placenta accreta syndrome, now's the time that every obstetrician has to think electively in the antenatal period. So rule out past, rule out, be prepared with your team and think about internal iliac artery at the outset. And in emergency, I would say, wherever there is valtrexis, that would be a case where when you're dealing with the repair of the vault, better to ligate vessels and then, because I did this on 4th of November 2022. So I thank Foxy that it has given me a platform to learn at my age how to ligate, and I did, and we could save the uterus and the patient. So I would like to share this video. It is a long video, 8 minutes, and it's done by my colleague who's really committed with me. Dr. Arup, who is going to come, is also my committee person, my expert. And this is with Dr. Shashi. I'll need 2-3 minutes. So this is a case. It is an emergency actually. The beauty is this is not a teaching video. So I always like to show this if I have time and if the audience is also interested. So here the patient had delivered outside vaginally and she had gone in shock 2 times. And the 3rd time when the patient had reached her, so they had taken her up and they did a hysterectomy. I have not shown the earlier side because I told her only the internal iliac. And you will see that even in emergency, you can do internal iliac if you are actually that expert. So opening the peritoneum and basically using your fingers. मैं जल्दी से दिखाऊंगी यार. And using your fingers to dissect and separate and expose. So basically all those diagrams about the pelvis and looking at the way anatomically external iliac artery and internal iliac artery are placed, it's very easy to make out. And I'm not going to go into the finer details, but you can see that here ureter is our friend and it is always kept in the medial side as a guide, because in ureter will be coming on the common iliac artery and then going along with the internal iliac artery. So in this picture you can see very clearly that the psoas muscle and the external iliac, they are running side by side. Over the psoas will be the external iliac. So here you can see that this is the common iliac, this is the external iliac, this is the internal, and here is the ureter. Actually ureter is always a giveaway because of the peristalsis that you can see. So basically I'm not going to discuss the technicality, but I'm just going to show you this video that it is actually adrenaline secreting video. So having both the vessels, the internal iliac artery and the internal iliac vein, they are in total very close to each other. So the dissections have to be parallel, gentle, and it's not so difficult. And provided we all do it, look at it, and lateral to medial and then ligating the vessel. So basically whenever we are dealing with hemorrhage in PPH, the key messages is to recognize, not be ignorant and ignore it, delay in the diagnosis. It's an example of efficient multitasking, and it's a teamwork. Everybody has to chip in, all your staff, your doctors, your colleagues. Some surgeon, to begin with, you don't know, but somebody would be knowing and quite proficient. And in my opinion, I think every obstetrician has the opportunity to be familiar with the pelvic vasculature, and it is imperative कि हम सबको internal iliac artery pelvis में कहाँ placed है ज़रूर palpate कर लेनी चाहिए, because our patients are living and the vessels are pulsating. So thank you so much. Thank you.
Thank you, Dr. Beena, for a nice, nice presentation. One thing must you know, while you try in artery ligation, myometrium should be taken because it will destroy it. And while ovarian artery ligation, one should not puncture the venous system. We must know the anatomy also, and I think documentation should also done properly what we have done, which type of vascularization, which type of compression suture we have done, so that next doctor should get very nice presentation.
See, actually, first step is every obstetrician should know what all can be done. So, do you know compression sutures? Do you know how to do stepwise devascularization? Do you know how to ligate the internal eye? Do you know how to do obstetric hysterectomy? Then the second is when to do what. So that actually comes with dealing with emergencies, and also this S1, S2 segment concept. You know, I found it so important and interesting. Also, I have some few cases where patient had recurrent vulval hematoma, and actually it was a retracted internal pudendal, which could not have been tackled by hysterectomy. So you had to ligate the vessel.
Yeah, thank you. Just a question that if we will start the devascularization from above to downwards, like tubo-ovarian vessels, then uterine, and then it will the wastage of time. But we should start the tubo-ovarian, then uterine.
Sorry,
or no, ligation.
No, ma'am, actually, see, the uterine supply 90%.
That's
so you have
why.
to first ligate the uterine. You have to actually, it's not कि आपने चारों करने हैं.
नहीं,
आपने
चारों
uterine
नहीं.
कर लिया और
First.
अगर bleeding कम है, you don't have to do.
Okay, time is very less. Otherwise, I can show you. Thank you very much. The third and is very nicely, but you have explained all the, and your video was very, very good, especially uterine artery ligation. It's a very, very nicely. Now the third speaker is none other than Dr. Arup Kumar Manjhi. He is an ex-professor and head of department, Calcutta National Medical College, and he is a very good author. And my friend, very closely my friend is there when I was HOD, and good author. All the books that I have distributed to my student, and I have read also. He is going to speak as very, very important and one of the very complicated in that in emergency OT that we are facing. All the juniors or seniors, they are facing uterine, that is the placenta accreta, and sometimes we lose the uterus. So he is going to speak on this placenta accreta and its management. Dr. Arup, so we are anxiously waiting for his lecture.
Thank you,
evidence based.
Other chairperson, for nice introduction, and I am really, really thankful to the Dr. Olka Pandey and her team, the very enthusiastic and vibrating team here. And compiling these three topics, all are life-saving. And previous talk was the first talk was Dr. Jha, it's excellent. And Dr. Mitra Saxena is throughout the India, he is roaming from here to here, how to save the life by practical obstetrics committee. And she has inducted me in her committee, Dr. Mitra Saxena. And thank you. Thank you. I am actually, that I will coming to later. But my topic is placenta accreta spectrum. And only few years back, 1 decade back, it was a really nightmare to all obstetricians. Nightmare, nightmare, and nightmare. But only for few years, 5 to 7 years, there some evidence-made solution has come. And particularly after the introduction of the NICE guideline, after the introduction of the ECOG guideline, and latest is the FIGO guideline, they tell everything in the same tone, what should be the management. So next few minutes, I will say about how with the management of the placenta accreta spectrum. Placenta accreta term is very, very poor. It was a term first coined in 1937. And after that, it was got importance in the 1966 when the placenta, through compiling all the placenta disorder. Various nomenclature, all you know, popularly known as the morbid adherence of the placenta and placenta accreta spectrum, also placenta accreta syndrome. A range of pathological adherence of the placenta. FIGO has classified categorically grade 1 placenta accreta, grade 2 placenta increta, that myobacterial invasion, and grade 3 the Sirascos had touched. And when A percreta limited to the uterine serosa, and grade 3B urinary bladder invasion, and grade 3C with invasion of the other pelvic tissues and organs. Associated with significant morbidity mortality if not managed properly and planned properly for the management. And average maternal death is 7%, and there are so many morbidity I am not going into detail. Most concern is the remarkable rising frequency. Now, what are the different changes in the placenta recently? 100 years back, the incidence was 1 in 20,000 births. And in 1980s, it was 1 in 2,500. In 2015, 1 in 731. And more recently, it is 1 in 270. You cannot imagine that Monica Anand was the postgraduate, it was 10 years back. A very fair, he was my student, and very, very less number of placenta acreta morbidity. But now, in every week, for your information, Monica, 1 or 2 placenta acreta spectrum come and done by the register and also the third PGT. And actually, the cesarean section is to me the treatment of choice following cesarean delivery if it is really placenta acreta spectrum 3. And evaluation by the imaging is the mandatory. Why so rise? This is a great concern. Is it, definitely it is the rising rate of the cesarean section, and increase other risk factors also like the non-surgical and other surgical causes. And surgical techniques of the cesarean section, if there is any role of the different surgical for causing the placenta acreta section. Prior cesarean delivery, the risk rises as the number of prior cesarean sections increases. Placenta previa is associated with more than 80% of the cases. In 3% of the cases, women with placenta previa without prior cesarean delivery. The combination of the placenta previa and history of prior cesarean delivery has highest chance of, if a patient come with prior CS and placenta previa, you always think that maybe the placenta acreta spectrum managed like that. Now, important issues is the technique of the cesarean section, is the type of the sutural material used, is the effect. There is no definite answer. However, the NICE guideline clearly says that single layer suture and the suture material used in the repair of the CS wound may be potential concern of adherent placenta. According to the NICE guideline, effectiveness and safety of single layer closure of the uterine incision is uncertain, except within a research context, the uterine incision should be sutured with 2 layers. This is the standard method of the 2 layer. And the more prospective multi-center studies are required to evaluate the impact of surgical techniques used during cesarean delivery on the risk of the past disorder in subsequent pregnancies. The FIGO 2018 concluded like that. Now, antenatal diagnosis is very important. It needed for planning of the management. The history of first and second trimester vaginal bleeding, cesarean section pregnancy, it is the spectrum of the same disorder. If the cesarean section pregnancy continually is likely to be placenta acreta, the presence of the risk factor, presence of the placenta previa, prior cesarean delivery, and the presence of the anterior low-lying placenta, always the think of the placenta acreta. Placenta acreta index has been, recently there is scoring has been done by the Julie et al. Important from the history and the ultrasonography in 2020. Imaging and sonography, imaging, that is the sonography is the most important, MRI is not all cases. Ultrasonography is the first line for the diagnosis of the past disorder. MRI is not essential but may be useful in evaluating the pelvic extension of the placenta acreta or areas difficult to evaluate on ultrasound. Sonography, there is a clear-cut finding is the cystic spaces, hypoechoic zone, and myometrial thickness less, and placental branching, extension of the placenta into the myometrium, serosa or bladder. On color flow or turbulent lacrimal flow, MRI is not essential, but it is important in case of posterior placenta previa and to assess depth of the invasion, lateral extension of the myometrial invasion. Screening is of the past, like the shortening of the cervix, it should be the routine, but no such important guideline. If an woman with during fetal anomaly scan, placenta acreta spectrum is seen. There is no clear-cut guideline in number and optional time of the screening. Approach in management in planned delivery, tertiary care center, and base schedule at the daytime. Now, when you will deliver within the 36 weeks, like the NICE guideline, SEOG, and NICE guideline says within 37 weeks. 1 week defer, there is a chance of bleeding. Earlier delivery where there is an indication. Corticosteroid is recommended before 37.0/7 week. Pre-operative consideration is the maximum of the counseling, consent for hysterectomy. Many prefer urothelial catheterization, interventional radiology if available, placement of the balloon tip catheter into internal arteries for inflammation after delivery, for occlusion of catheter for embolization. Type of surgery, caesarean hysterectomy, conservative or expectant approach only in case of selected cases. Caesarean hysterectomy without attempt the placental removal is the treatment of in case of diagnosed cases. Anesthesia, regional anesthesia, but can be transferred to the to convert to the general anesthesia if required. At least 2 large IV cannulas should be placed. Now the steps, important step. Vertical skin incision is the best option. Next is the inspection of the uterus. You can see the uterus. There is that engorged vein. It indicates the placenta accreta. And to mark the upper level, you can see mark the upper level of the placenta. You give incision over that, over the fundus. It is not basically actually the classical caesarean, it is more higher than that. And longitudinal incision above the level of the placenta. Baby is delivered to fundus. It is was breech presentation. Cord is clamped and cut and reposed into the uterine cavity, and it is the repaired. Uterine cavity is repaired. Searching for the internal ligation, you can see. There is no time. Actually, the internal ligation is a very, very easy thing. In our institution, actually, I have retired just, but every third year PhD can do. And Dr. Saxena, Mr. Saxena, has actually, there is a large session for internal ligation multiple times through the there are some tips to do how to do that. This is the internal ligation. You can use either in the aneurysm needle or right angle hysterectomy procedure. And most important thing is the separation of the bladder. But if the bladder is damaged, maybe injured and open, which is repaired in layer, and post-operative bladder drainage is given for prolapse period. Hysterectomy completed, you can see hysterectomy completed, and there is no bleeding here. Complete hemostasis is done. Now this is the video. You can see the incision is given at the fundus, longitudinal incision through the fundus, and the baby is delivered. This was the breech. That same case actually. The same case, baby is delivered, and the umbilical cord you will have to clamp and repose inside, and the uterine wound is repaired, and is really that there is no such bleeding in all cases. If you do select the place. And the internal ligation is done on right side. You can see internal ligation. Actually, basically, there is a fossa in between the vessel. If you can separate the fossa beforehand, there will be very easy to do the internal ligation. That is the tips of the internal ligation. I have told in many sessions of Dr. Mr. Saxena. And next is the opposite side, the internal ligation you do. I have not showing the opposite side, you will see. And every resident, third year resident, should be trained over the internal ligation. Though internal ligation is not routinely recommended in SEOG in case of placenta accreta section, but this has certainly there is benefit of the internal ligation. You will have to do practice this internal ligation. And next you can see the opposite interiliac. I will skip this. Probably Actually, there is a time constraint, and the hysterectomy is proceeded. And the clamps from above downwards as usual manner. The most important clamp is always, that is the pedicle, is the containing the oophoreal ligament and the fallopian tube. There is a, sometime there is a bleeding after the operation in the post-operative period. So that ends to be ensured. Now after the interiliac artery separation of the bladder, that a fine dissection is the needed for separation of the bladder. You can take the diathermy, fine diathermy, and the opposite side. The separation of the bladder and complete hemostasis. The vault is being cut. The separation is done. The vault is cut. And you can see there is no myometrium here. Only the serous coat on incising there. And no serous coat and no myometrium in this specimen. That there is possibility of the bladder injury, but this patient there is no injury of that. If there is a bladder injury, you just repair it, no problem. And from the back of the uterus. The additional therapy is the controlled severe hemorrhage, the pressure, pelvic pressure packing and aortic compression. And the platelets, RBC platelet, FFP and platelet 1:1:1, 2:1:2:4. Tranexamic acid is used immediately prior to or during cesarean delivery. Utotonic is withheld. Remember it. When you want to take the decision, the placenta institute the hysterectomy, don't give utotonic, but there is a chance of placental separation and the bleeding. When you have decided the FIGO recommendation, this is the FIGO recommendation. In the absence of the spontaneous placental separation, the placenta should be left in situ to minimize blood loss. And total hysterectomy is done preferable to the subtotal hysterectomy. Deliberate cystostomy and excision of the involved bladder may be considered in case of the Percutta villus tissue involving the bladder. Just a few minutes. Conservative management, it is to avoid the postmortem hysterectomy. These are the FIGO 2019, leaving the placenta in situ. And second is the exploratory technique, one-step conservative surgery, triple position. These are all described in the FIGO, and that is also recommended in some special cases. Living in the placenta in situ, there is a chance of the secondary necrosis, so follow-up is needed for secondary hysterectomy. The exploratory technique, this was done also in my institution. It was done previously, and the patient go into severe hemorrhage and the cardiac arrest, coagulopathy, cardiac arrest are injuries of the adjacent structure. So to conclude, dramatic rise of the incidence is of great concern and right mind to the obstetrician. Antenatal diagnosis, especially by ESG, is very important for optimizing management. Planned cesarean hysterectomy without attempt of the removal of the placenta is preferable. Conservative or expected management is considered only for carefully selected cases. It is best to save both mother and uterus. But losing a mother in an attempt to save the uterus is the greatest tragedy in obstetrics. This has been written in my chapter book, in the chapter at the end of the postpartum hemorrhage. This is really an important message. Thank you all. Thank you, madam. She is very.
I know. Actually, due to the oration, we have to rush, and the time was also up.
Thank you so much, sir, for your wonderful presentation, sir. It was really very eye-catching, and the video was so clear and good to learn this thing that before doing hysterectomy, you have ligated the internal iliac, and the bleeding is really less. This is good.
Antenatal diagnosis is the most important actually.
Yeah,
All right.
During hysterectomy, you go is the transpondal incision.
Okay,
And
sorry to
like I said,
interrupt
it's better
everyone. Can we do the offline discussion? The oration has started. So let's do that discussion.
Because of shortage of time, there is no
We will
time
resume
for-
back after the oration. We have few more sessions coming up here. We are just checking if we can relay the oration here so that you all can continue to sit here. I'm just checking that.
You come with me.
well equipped. So you need to first stabilize the patient, do the source control, escalate your care, and then anticipate and prevent adverse pregnancy outcomes. So these 10 pearls are very important, and the whole management lies in this. So talking about the early diagnosis, that is very important, but we know that the physiology is going to have problems. So what are we, this is the MUOS index, maternal early warning obstetric signs. So here you see the white one being the normal, the yellow is the yellow alert, that is you are readily prepared, and the red alert when it comes means the patient has a severe problem, that is patient is neurologically not responsive and the parameters are really high. The blood pressure, the temperature, respiratory rate and heart rate needs to be monitored. So it is a simple, the advantage is a simple screening stool on the bedside, but disadvantage is that it is not validated for chorioamnionitis, that we cannot, chorioamnionitis patient may be having some criteria but maybe little stable. So you need for sometimes secondary testing also, because there may be, we cannot know the specificity and the sensitivity is not very good. Then comes to have that we have a sepsis in obstetric score. This is again a scoring system based on the general condition, that is heart rate, temperature, respiratory rate, oxygen saturation. But here you can see there is WBC count and lactic acid and all the lab parameters come into picture. So here, because of the lab parameters coming, your excellent negative predictive value is there almost 98%. And rapidly rules out ICU. You know that the counts and your everything is normal. You don't have to put the patient in the ICU. And it does not use an altered mental state as a criteria, because altered mental state in pregnancy can be of many reasons, and sepsis being one of it. So you really need that this is rapid simple, but only disadvantage is that it requires a lab help. So the time, some valuable time can be lost because you require some time for the investigation report to come. Then we have obstetrically modified quick sequential failure assessment, that is SOFA index. So here there are 3 criteria, that is systolic blood pressure less than 90, respiratory rate more than or equal to 25, and altered mental states. And if we find that more than 2 or 2, if the score is there, so there's 1 point given to it, it is associated with high risk, poor outcome. And it is really a screening test. It is very rapid test, rapid diagnosis. Only thing, there is an altered mental status is there. So really some non-septic causes also can be confusing, and sometimes they may need secondary testing. So the best tool for identification is actually unknown, but what clinically the MUOS or the SOFA index is something which can predict the end organ damage and can early recognize the sepsis. So now we have our tools for early diagnosis, and we all know the causes. I'm not going to go into detail because we know the obstetric causes that is related to delivery, but there are non-obstetric causes of sepsis. So whenever you see in mind, you need to keep the vision box open, thinking about pyelonephritis, appendicitis, bowel perforation or bowel infarction, pancreatitis, even viral infections, or these can contribute to sepsis apart from the obstetric causes, which the most common is being retained products, chorioamnionitis, endometritis, wound infection, very common. And these are the predisposing factors to this, that is the social factors, the socio-economic condition of patient, the hygiene, everything. The medical disorders in pregnancy are going to really, a pregnancy with immunocompromised state like HIV or with diabetes, anemia, they're going to cause, and then the childbirth related incidents. So when we talk about the common cause, we know the pelvic, non-pelvic, and it can occur at every stage, that is intrapartum, postpartum, and even antepartum. And the causative microorganism needs to be identified almost in 64%, and the source also needs to be identified. And the most common is being the Escherichia coli, group A and B streptococcus, and at times it is mostly a mixed infection. So you really need to choose the antibiotic very, very rapidly and vigilantly. So when we talk, these are the causes, how the patient will present. I'm not going to go in detail. Everybody knows how a wound infection, endometritis, but fever would be there when there is that will be classical in chorioamnionitis, endometritis, respiratory tract infection, and breast abscess. So these are the patients typically with a fever and a local symptom. Urinary tract infection, very common. Then comes to malaria, meningitis, toxic shock syndrome. This can happen with a forgotten some gauze piece or a tampon, and we really see the other signs, that is lethargy, nausea, vomiting, patient coming into collapse state. And end organ damage, when you're talking about sepsis, it is going to affect all the systems, right from the central nervous, cardiovascular, pulmonary, gastrointestinal, everything. And urinary system will be the first to be affected. You will see fall in urine output, oliguria, then patients going into DIC, and then end-stage failure. So the clinical parameters, we talk about everything when we know how a patient will present. But believe me, I tell my people that sepsis patient may not always be coming with fever. Sometimes you see a patient in a very altered state, cold, climby, little air hunger, gasping. Those are the patients also who have sepsis, because they are really cold, climby because of the excessive bacterial load in it, and they really are having an air hunger. So that tachypnea, they're classical symptom, and then if you give antibiotics, stabilize the patient, give fluid therapy, you can really treat it, and laboratory findings will definitely support maybe the cultures, doing the acidotic metabolic acidosis by doing serum lactate, the ABG level, the creatinine, the liver enzymes, you know, all DIC profile, everything needs to be done. So this is complete investigation panel. You do it in addition to the pelvic ultrasound and the CT and the MRI, along with all the cultures, everything, the blood, urine, everything, the electrolytes, and then role of biomarkers. So procalcitonin, guiding the antibiotic therapy, shows promise. The NICE guidelines support it. The surviving sepsis campaign also says, but little low quality of evidence is there, and serum lactate is a useful biomarker, and if the repeat measurement required, if the values come greater than 2 millimoles per liter. And maternal and perinatal, we know all the outcome. I'm not going to go in detail, but the early screening and management at all level, that is by cultures, by following appropriate antibiotics, then identification by the criteria which we discussed. The patients with infection and hypotension are given the crystalloid solution, reassess their volume responses and tissue perfusion, and then achieve a CVP level also, a CVP line with more than or equal to 8, and proper oxygen saturation to be maintained for this patient. So sepsis 6 is a 6 set of tasks, including oxygenation, culture, antibiotics, fluids, lactate management, and urinary output. This all needs to be instituted within 6 hours, and this is the backbone of the sepsis care bundle. So the antibiotics, what we commonly use are the mixed antibiotics, which are you using in your setup, basically a cefotaxamine, you can add in a metronidazole, or a gentamicin, amikacin. So all spectrum needs to be covered. There is minimal role of corticosteroid, but source control is a key, that you need to, after stabilizing the patient, control the source. DVT prophylaxis in way of low molecular weight heparin or an unfractionated heparin really require. You can give compression stockings because this patient will be in ICU for a very long period. So this is the key. Just last half a minute. So delivery decision should actually be prompted. If a patient is sepsis is not the indication for delivery. So you really need to know that the decision of delivery is merely for an obstetric reason. If patient is having some fever or some, just don't rush into deliver, stabilize the patient first. Indicators for delivery will be intrauterine infection, if there is a DIC, hepatic or renal problems, in any heart conditions, multipetal gestation, ARDS, so all that will be the factors for delivery. And we can use epidural or spinal anesthesia, should be avoided in this patient, and general anesthesia is required. ECMO can be in the refractory sepsis. So ending with the take-home message, physiological changes of pregnancy must be actually differentiated from the features of sepsis. Always maintain a high suspicion, high index of suspicion. Implement a rapid bedside tool for detection. The diagnosis of sepsis should be considered with otherwise unexplained end organ damage in presence of infection, regardless of the presence of fever. Empirical antibiotics should be administered within 1 hour. Cultures, blood, urine, respiratory, serum lactate must be done. Early administration of 1 to 2 liters of crystalloids are really required for the hypoperfusion and hypotension. Use of norepinephrine as a first-line vasopressor with persistent hypotension or hypoperfusion despite fluid resuscitation, and no immediate delivery for sole indication of sepsis. So with that note, I would end that optimism is a faith that leads to achievement, and nothing can be done without hope and confidence. And I thank you all for your patient hearing. And at the end, I would just make a request, a humble request and an earnest request to all of you to support me for my candidature and encourage me for the post of Vice President of Foxy from the West Zone. I come from Mumbai and I love Patna and I love all the people around here, and I am requesting for a good support from your place. Thank you so much.
Thank you, Dr. Komal. It was a wonderful presentation. And on this important topic, your talk represented the key element of the management of sepsis. I think all the obstetricians some or other time face such cases, and your bundle, this 3, 5 or 6 bundle care, very much helpful to all of us. Thank you for that.
Thank you, madam.
Now we'll invite our next speaker for the next talk. It's none other than Madam Dr. Yashodhara Pradeep. She is Vice President Foxy and loved by all of us. We have a long association with Madam Yashodhara Pradeep. She has been Vice President of Indian Menopause Society as well, and has keen interest in many conferences and has been actively participated and organized many conferences. And Madam will be talking on pregnancy with platelet disorders. So over to you, Madam, for your talk.
Thank you, Dr. Usha, Dr. Nibha, and other chairperson for the kind words, and for all the audience, because I always say that Bihar and Jharkhand is my second home. I have been introduced, I always remember, by Dr. Rangila Sinha into the Bihar, Jharkhand, and then AICOG, and then Dr. Usha Didwania and Nibha has become very fast friends. So this time starts now probably. And it is 20 minutes.
अभी क्लॉक को स्टार्ट करिए. अभी निकले जा रहा है.
हाँ, अच्छा ठीक है, okay. I thought it is 20 minutes is a keynote. 15, okay. So I'm going to start. This is a very long topic. I will not be able to cover everything in 15 minutes time. I thought it is a 20 minutes. So it is only 15 minutes and I will not be able to cover, but still I will try to give you some messages. So practical tips which you can use for your patient management, and that is the point of giving any talk. So it is the platelet disorder. It has not been changed. So it is, there's two types of the disorders. There's one thrombocytosis and thrombocytopenia. We always talk about the thrombocytopenia, but we forget to talk about the thrombocytosis. It is also an important part. When you look at the CBC report, you should also see the platelets not only within normal limits, it should not be more than normal limits, which I am just going to tell you. So it has been defined as an elevated platelet count more than 4.5 million per ml in a peripheral blood. So if you see that it is more than 4.5, because 1.5 to 2.5 is a normal, then 2.5 to 4.5 is a gray area, and then if it is more than 4.5, it will land up into the thrombocytosis. It's not changed. Yes. Yes. I started instead of 15 at 12 minutes. So it is caused by either by the increased production, which is happening, that's known as reactive thrombocytosis, and it is 88 to 97%, or the clonal expansion of the megakaryocytes, that is a clonal thrombocytosis. So incidence is 1 to 2 per 100,000 population. Prevalence is 38 to 57 per 1,000 population per year, and more common in the female, 2/4 is more common. and clinical presentation is not in the young age, it is in the older age. So I am not going to talk more upon it because I am talking in relation to the pregnancy. So what I just want to say, it is also occurs in pregnancy and it causes lot of problem. So what I just want to say, this problem occurs because of the JAKT2 STAT pathway, including the JAKT2, CALR and MPL gene mutation. So reactive thrombosis causes history and physical examination. So you have to see that it is not acute blood loss, iron deficiency, acute or chronic infections, medication use, asplenia, malignancy and the trauma. So these are the laboratory tests you have to do. You have to just find it out that it is, because in some cases, ये बंद क्यों हो गया भाई? full slide कहाँ से होगी आपकी? हाँ, क्योंकि मैं तो Mac use करती हूँ, so I'm not familiar with it. And आपका तो बहुत पुराना है. Yes. नहीं, वहीं से next कर रहे थे. मैं तो सिर्फ pointer option लाई थी यहाँ से. So it all happened because of the pointer option. Yeah, now it has come. So it is not very visible. I can choose another pointer option. That's laser pointer पे कर दें. चलिए, आपके पास वो नहीं है, arrow pointer नहीं है. नहीं, I mean say pointer option में, उसमें नहीं है, ठीक है? ठीक. So serum C-reactive protein ESR. What I wanted to say, see the peripheral smear. If this is Howell-Jolly bodies or target cells are present, that means patient is having no spleen, she is a patient of asplenia. Or if it is a serum, otherwise it is going to be the normal thrombocytosis. As I said, reactive thrombocytosis is the most common because we see in all anemic patients. Let me clarify it because I may not be able to explain at that time. So whenever you see the patients are anemic, you will see that thrombocytosis is also there. People will say now because the normal values are written. I have seen many times a patient says, Madam, ये हमारा बढ़ा हुआ आया है. And then if you are not able to explain, they go and do the Google check. And then they say, अरे डॉक्टर साहब हम तो उनके पास गए थे और वैसा हुआ पता नहीं मरीज क्या क्या कहते हैं, आपको भी पता है, हमें भी पता है, सबको पता है. So we have to be only careful. So non-specific markers are ferritin level and serum irons are low. Rest is, if nothing is possible, if nothing has come out into the test, then you have to test for JAK2 V6-117.5 mutation. If it is negative, then you have to see various other mutations. I am not going into the detail of it. Again, this is a picture in which you can see the platelets in the various stages of the maturation. So it is pregnancy, because I am saying, so it is there's both maternal and fetal complications occur because of thrombocytosis. So it is a cerebral complication, cardiac complications, abdominal thrombosis, deep vein thrombosis of the legs. And fetal complications are abruptio placentae, preeclampsia, placental insufficiency, fetal death, unexplained abortions, stillbirths, unexplained fetal and placental malformations, and preeclampsia. So it is very important, but when the treatment part of the treatment comes, there is a cytoreductive treatment is there. So there are two important compounds are there. One is hydroxyurea and second is the interferon. So interferon is preferred over the hydroxyurea. This is a grade 1C, evidence is there. So this is, again I am not going to talk because a international prognostic score for the essential thrombocythemia or thrombocytosis. So again I am not going to talk, it has got all associated with cardiac disease or not, venous thrombosis or not. It is being given, aspirin is the main treatment, but it should be given in what doses, once a day or twice a day to prevent thrombosis. So again, I am not going to talk because of the time constraint, and the goal of management is basically to prevent the thrombotic and hemorrhagic complication and alleviate the symptoms, because it presents with the vasomotor symptoms. Because of thrombosis, it is going to cause less blood flow, and so it is going to cause a vasomotor symptoms. So this is a pre-treatment evaluation. You have to just go into the history and see that she has got many abortions, and you see the picture. And sometimes if it is, you are still thinking that this is a case of, because this is the placental vessels which are getting thrombosed, but it is not coming into any of the investigation. You can see the mutations also. So management, as I already said, so I'm coming to the thrombocytopenia, which is more managed into more commonly you manage every day. So these are the common causes, uncommon causes and rare causes. So common causes, gestational thrombocytopenia, everybody knows, and severe preeclampsia, hemolysis, HELLP syndrome and DIC. Uncommon causes is immune thrombocyte ITP, APLA and SLE and human immune deficiency HIV. Rare causes is TTP and HUS. These are rare causes, but what I am just trying to emphasize by this, that one should not, gestational thrombocytopenia everybody knows, and everybody knows probably how to treat it. Only thing I have to going to emphasize that don't be panic and don't make the patient very apprehensive, because I have seen many times the patient comes and says that हमारे डॉक्टर ने बताया है कि ये आपकी platelets बहुत कम है. If it is really less, then you have to say. Otherwise you say हाँ थोड़ा marginally है, we will just keep in check. So patient's apprehension, because of the apprehension, she goes door to door and she changes not one, many doctors. So our goal is also, or our duty is also, we should not make the patient very apprehensive. So she is going pillar to post, and sometimes she is getting the anxiety problems also, and she has been treated for that. So this is only thing which I would like to say. By HELLP syndrome, DIC, DIC I'm not going to, because I will not be able to talk on all the causes, but HELLP syndrome is one which you are also treating day and night. Probably in the COVID, maximum topic has been covered by on the HDP pregnancy and HDP disorders and HELLP and preeclampsia probably. So, but I will just try to touch upon the immune ITP, TTP and HUS, because these are important. They are rare, but they are important. So if you do not find, as I said that gestational thrombocytopenia is a long history. It is only that if you get between 120 to 149, because as it has been seen that Indian woman ethnicity plays a role, and Indian woman has got a slightly less platelets in comparison to the Western ethnicity. So it has been said that it is 120 to 149 millimeter per 1000 per millimeter square. You will find it between in the 10% of the women. It is not less, 10% of, because now we are getting the CBC for each patient. Otherwise we used to get only hemoglobin percent, and so we are not able to correlate well. But since we are getting the CBC done, we are seeing more and more. But 1% of the patients will also have 50,000 per cubic millimeter, the platelet count. So 50,000 to 99,000 per cubic millimeter. But this is not a great risk to the mother and fetus. That is only thing I would like to say. You keep in observation. That means, doesn't mean that you have to get a platelet done every day. Once you have got a manual platelet done, or in the citrate blood, instead of EDT, it should be in the citrate blood. It should be, so the platelet clumping does not occur, and manual count is important. If you have done and you have seen that it has come between the 120 to 149, you are happy, because I have seen that 20 to 30,000 difference occurs between the manual and the this machine analysis because of the clumping of this thing. So they require no therapy, and not every day measurement. It should be probably 6 weeks or 8 weeks, you can see. Otherwise also we get in the 3 trimesters, first trimester, second trimester, third trimester, the CBC and the hemoglobin done for the better outcome and better management of the anemia. So platelet count is less than 50,000 or platelet count is less than 20,000, it needs other investigation. Gestational thrombocytopenia has got no other investigation. So I will just say 2 or 3 cases and I will try to find it out. Again, the time, it is 28 years, P430. She had 2 stillbirths and 1 preterm delivery. The baby died immediately because it was only 28 weeks. She came to me nearly 2-3 years back. So she was only 10 weeks and the relatives were really apprehensive, and they were, she was also related or to some of our employee. So we have done all the tests. but nothing has found out, nothing was positive. So what we have done, it is in this stepwise investigation should be done. So this is the first set of the investigation we done, and in the first set of the investigation we had 3 important findings: the anemia, the thrombocytopenia, and the pancytopenia. Rest, then we ordered the second set of the investigation. Second set of the investigation, we have found that B12 deficiency and folic acid deficiency and the increased AST. Iron is also less because it was the anemia was there, but whole abdomen ultrasound was the diagnostic for this woman, because it is the one who has diagnosed portal hypertension. And then the diagnosis of cirrhosis, and everything was settled, and we had kept our gastromedicine and the hematology person in touch. So she used to visit us and also visit to hematology and this thing. All the hematology used to say that we are not going to do anything till she delivers, but the GI person has to see for the varices, because portal hypertension is common, but we could not do it because all public hospitals are so much loaded. Nobody is going to take such serious patients which is going to take so much time, and your salary is the same. It is not that Medanta is going to give you the sum. So in there, if the patient goes, immediately it will be done, because they are going to charge 2 or 3 lakhs rupees for that. So high risk factors for this patient is this, and management was the consultation, as I have already said: anemia correction, deworming, continued antenatal care. These complications were explained, but then it was again came, because it was 10 weeks, whether we should terminate or we should continue. But because she did not have any live child, it was already 3 losses were there, and she had chronic liver disease which is going to deteriorate with time. So we said that she is going to continue, and we have tried to see the esophageal vessels, but it could not be done. So we have just delivered this woman with a very good antenatal care, close monitoring, and we delivered at 36 weeks probably this woman. There is no guideline about the vaginal or this birth, so we did a C-section because it was not in labor, it was 36 weeks, so cervix was unfavorable also. Contraception is must, because otherwise this woman is going to face a lot of problems. So we have given her Kautaliya, postpartum Kautaliya, that was also birthed. So this is another case, which is a 28-year-old woman presented in the emergency department for, because there was a lot of confusion was there in that time. So it is, she was presented with the bleeding. So she had no family history, nothing significant history. So on examination, there's a gingiva was problematic. So she went to dental surgeon. They have done something, but then she came to the obstetrician, and it was seen that she is having a problem of some petechial hemorrhages and all those things. And this was the picture of her. So she was given all the investigations, and it was in these investigations only it has been found that she is having a non-specific enzyme reactive antibodies. So management was with the tranexamic acid, parenteral prednisolone was started, and intravenous immunoglobulins also started. The platelet was at that time only 2 into 10 to the power 9, but it increased to 41, and then she was discharged with the prednisolone 40 milligram orally for 20 days. And there's another thing we could have done, that is a splenectomy. But this patient who has come in the 12 weeks, she has followed up, and she has grown till 40 weeks with the platelet of 50,000 or something like that, and she has delivered vaginal birth, and gradually the prednisolone after the delivery has also increased to 126 into 10 to the power 9 per liter, not the microliter. So it will be, if you are doing into the microliter, it will be 10 to the power 3. So this was, because we all know ITP is a self-limiting disease. So after the treatment, after the delivery, it was self-limited. But the discussion comes, differential diagnosis. In this case was the preeclampsia, HELP syndrome, TTP, and HUS. Preeclampsia, we know all the features. Because of the time lag, again I am not going to talk. HELP, I am not going to talk. So we are just saying TTP, that is a thrombotic thrombocytopenic purpura. It is rare, but you can see UK and USA where the health situations are different, and so you see the rise in this thing. It is not because of the ethnicity, because ethnicity is more common in the Africans. So it is not the ethnicity, it is only the things are available at your place, which you can help in diagnosis, because I know I lost 2 of the patients, 2 mothers because of this, but we could not confirm the diagnosis because they came in a very poor shape and the time was less, and we could not do the plasma exchange because it was, even in the government hospital, it is very expensive. She could not afford, so she died. 2 patients I am telling you, and this patient, one came first time for something IUD, we delivered, again she went back, but because we did not suspect at that time. We thought it is a help, because of that she had all this. But second time when she came, then we were very alert and we had all these problems. So this is the inactivation. The diagnosis only is, it is a clinical diagnosis because you have to start the treatment very fast. Otherwise, your patient will die, as I have lost 90% mortality is there. So you have to start preparing for the plasma exchange. But in the meantime, you can also send and you can see confirm the diagnosis by ADAMT. S13 activity is 0 in this case, inactive, or it is decreased. So this is the final diagnosis. Coming to the last part, HUS, that is similar to TTP. So it is difficult to diagnose. We had one patient, we were just thinking it off, but we could not do it. Only difference between the 2 is the age group. The TTP is more common in the middle age, the HUS is more common in the adolescent and the infant. So it is the children and the adolescents. So it is the history of infant blood diastasis is important, because these adolescents are in our group, in our country, is also getting married. Teenage pregnancy is quite high in this thing. So these patients sometimes come. So if the teenage pregnancy coming with this disorder, you must keep this in mind. And acute nephropathy is more common with the HUS, but with the TTP, the neurological symptoms are more common. Rest 3 symptoms are almost common. So this is a, but here again, it will negative value will be ADAMTS 13 will be normal in this case. Rest all will be different. So it is a, I'm not going into the detail of it. And again, coming to the take-home message, remember that gestational thrombocytopenia, obstetrician must have the judgment in giving diagnosis, because no test exists for this order to diagnose more than that what we have already done. And if platelet count continues to fall and it comes to less than 50,000 or 20,000, you have to diagnose for another cause. So what are the learning points for this? Gestational thrombocytopenia is 75%, which is benign and poses no maternal or fetal risk. Thrombocytopenia secondary to HDP is 15 to 20%. Immune thrombocytopenic purpura is 3 to 4%. Rare causes is 1 to 2% is TTP and HS. 1 to 2% is out of 100 we are talking about the thrombocytopenia. A multidisciplinary approach is essential, and adequate dental is also important, because sometimes it is only because of the dental problem you are having the problem, instead of you are having the problem because of something thrombocytopenia. Because I said chronic infection and inflammation is also one of the cause of thrombocytopenia, and we have seen chronic diseases also. So you have to, if patient is having, you have to send it and see and observe. Thank you so much for the patient hearing.
Thank you so much, madam. In such a short time, you covered this difficult topic so nicely, and I think delegates must have taken your take-home message clearly, that platelets just less than 50,000 is not dangerous. They have to look after the other points, when to panic, when not to panic, and keep the watch. And I think your take-home message is quite important, and everyone is quite benefited with this. So thank you once again.
Can we do it like after these pics is over? Like, please invite the next speaker.
So in the meantime, may I call upon our next speaker, and she is Dr. B. Kalpana, and she will be speaking on recurrent pregnancy loss. And while she takes on the mic, I would just like to congratulate and thank Dr. Abha Rani Sinha and Dr. Nibha Mohan for the wonderful scientific program and giving us the opportunity. So Kalpana ma'am.
Good afternoon, everyone. Once again, I would like to thank the organizers, Alka Pandi ma'am, Supriya, Dr. Vanita ma'am, and all other dynamic organizers for giving me this opportunity. As we all know that recurrent pregnancy loss is a debatable condition. There was a debate starting from diagnosis, investigation and management. So approximately when we look into the incidence of recurrent pregnancy loss, it is almost 5%. The definition varies from guideline to guideline. It is variable in different countries. According to RCOG, recurrent pregnancy loss is defined if a patient has got more than 3 loss, but according to YESHRE and ASRM, if a patient has got more than 2 loss, the patient is labeled as recurrent pregnancy loss. We all know that various etiologies are there, and most common one is genetic etiology. It could be due to other causes like endocrine causes, anatomical causes, immunological causes also play a role. And we need to take a detailed history. If the loss is in the first trimester before 7 weeks, probably it could be due to genetic cause. And if it is in the mid trimester, we need to think about anatomical and also immunological causes. So coming to genetic etiology, we need to understand that even in sporadic miscarriage, almost 50 to 70% the POC would have some kind of aneuploidy. So it doesn't give us any clue about future pregnancy. Parental karyotyping may be normal in these cases, and it is related to maternal age. So should we go for testing products of conception? Is again debatable. The guideline doesn't recommend routine testing of POC for genetic analysis, but if the patient is very particular about knowing the cause, and if she doesn't want to go for further investigation like anatomical causes, endocrine causes and immunological causes, if she doesn't want to go for extensive investigation, but at the same time she wants to know about the cause of loss, then POC can be tested. Should we go for parental karyotyping? Again, it has to be decided by the patient and doctor. The guideline doesn't recommend routine testing of parental karyotyping. Yes, it is definitely needed if POC is abnormal, or if there is a family history of abnormal child, or the family history of previous genetic abnormality. In that occasion, we need to further test parental karyotyping, and the incidence is very low, 0.2 to 2.5%. Out of that, we have reciprocal translocation, which is quite common, and then also Robertsonian inversion also can happen in parental karyotyping. So when parental karyotyping is abnormal, what are we going to do? We need to give various options to the patient, because many a times 15% of patient would stop trying. They don't want to go for physical and mental trauma again and again, but few would try again. And in that occasion, we need to give the options of donor oocyte sometimes, and sometimes even IVF, PGT, SR, or sometimes naturally she can go on trying. But at the same time, we need to counsel that the live birth rate following natural try and IVF and PGT, SR is going to be similar, almost similar. And the only advantage of PGT, SR is if the embryos are abnormal, we can just avoid embryo transfer. Patient may not have few transfers, but at the same time miscarriage rate is reduced. So the patient has to decide what she exactly wants, and all the possibilities we need to tell. And coming to anatomical causes, we know that it is significantly increased in RPL patient from 5% to 15%, And in first trimester, septate uterus is quite common, and in second trimester, other anomalies like didelphic, bicornuvate, unicornuvate uterus can cause recurrent pregnancy loss. So the guideline says that all women should be screened for anatomical reasons, and simple 3D ultrasound will identify most of the lesions. If not available, HSG, SHG can be done, but MRI should not be the first line of investigation. So if the patient has got some uterine abnormality, what are we going to do? If a patient has got septate uterus, again it's a debatable condition. ASRM concluded that after correction, live birth rate is significantly reduced, but Yashre doesn't recommend routine hysteroscopic surgery because waiting for a larger trial to come to a conclusion. But at the same time, other anomalies do not need correction to improve live birth rate. And what about cervical? Because these patients are prone for mid-trimester abortion, you need not go for prophylactic cerclage. If the cervical length is less than 2.5, the patient needs cerclage. And coming to endocrine causes, we all know that it could be diabetes mellitus, thyroid and luteal phase defects, LH, hypersecretion. All these things need not be tested. Only diabetes and thyroid should be tested. And universal screening of patients for thyroid disorders like TSH and TPO should be done for all the patients. And if the patient is overt hypothyroidism, she has to be treated. But if she is if TSH is more than 4, she has to be treated and should be brought to 2.5. And in the first trimester, it should be 2.5, and second trimester 3, and third trimester again 3, even though there is some debate between American and European Thyroid Association. But if TSH is normal, only TPO is increased. Patient doesn't need any treatment, only monitoring is needed. So coming to thrombophilia, which is quite common, APLA, routine testing, we need to ask the detailed history. If the patient has got more than 3 pregnancy loss less than 10 weeks, or at least 1 loss after 10 weeks with no structural abnormality, or there is an evidence of placental insufficiency in the form of preeclampsia, then go for laboratory testing of these patients. That should be LAC, ACL, preferably, and also if possible beta-2 glycoprotein antibodies. It should be tested twice at 12 weeks interval. So if the patient is positive for APLA, start with low dose aspirin before pregnancy, and low molecular weight heparin when the fetal FH appears. Should we go for investigating hereditary thrombophilia? Actually, the guideline says that routine testing is not recommended, but if the patient has got family history of hereditary thrombophilia, or there is evidence of venous thromboembolism, in that occasion we need to test hereditary thrombophilia in these patients. Routine testing of immunological factors like HLA, uterine NK cells and peripheral NK cells is not needed, because immune therapy, intravenous immunoglobulin, donor leukocyte immunization, paternal cell immunization, trophoblast membrane antibodies, all those things are at research level, may be associated with sometimes severe anaphylaxis. So routine use of all these things is not recommended. And coming to male factor, should we go for DNA fragmentation index for all patients? Because ASHRAE guideline says that there is a moderate association between RPL and DFI, but he doesn't recommend routine treatment. Sperm selection technique is also not routinely recommended, but antioxidant role is again debatable. ASHRAE doesn't recommend routine use of antioxidant, even though Cochrane review concluded that there is a slight improvement in live birth rate with antioxidants. So it's again debatable thing. So should we treat other possibilities like hyperprolactinemia? Yes, we need to, but otherwise PCOS, immunological dysfunction, all those things need not be tested and corrected. So if a patient has got uterine Mullerian duct anomalies, it can be corrected. APS, it should be corrected. Endocrine should be corrected. Genetic, we need to give a great counseling. And what should not be done is immunological, need not be done, immunological screening, HLA determination, cytokine testing. We don't have enough evidence to recommend routine testing of all these tests and assessment of polycystic ovarian disease, LH, fasting insulin, glucose, insulin resistance, hyperandrogenism, all those things need not be tested in recurrent pregnancy loss. So whatever may be the treatment, ultimately it is the tender loving care which is going to give, which is the recommendation by the guidelines, because we need to counsel the patient about the possibilities she has got in the future, and tender loving care and sympathetic support will definitely encourage the patient to have increased live birth. Thank you.
Thank you very much, madam. Indeed, recurrent pregnancy loss is a very distressing situation for the parents, and we don't have much in our hand. Tender loving care along with optimal investigations and strong sense of clinical suspicion, I would say that there may be congenital anomaly, or we have to offer them what we have in hand. And so thank you for your very informative talk. Thank you, ma'am.
Thank you, ma'am.
Quickly for a group picture. Dr. Niba, please. We'll take one group picture. Quickly.
Do we have time for questions?
Yeah, we got 1.5 minutes left, so I thought we'll use it for picture.
If anyone has got any doubt or any query regarding all these three talks, speakers are here. Most welcome. I think talks were quite clear.
Dr. Yashodhara Pradeep, can you please come for a group picture quickly? Meanwhile, can I request Dr. Arun to hand over your laptop so that we do the technical connection? Dr. Komal Chauhan, she left. लैपटॉप लेके आइए डॉक्टर अरुण का. आइए हम जल्दबाजी नहीं करेंगे. हाँ तब तक लोड कर रहे हैं. All right, for this session 10 for the today's scientific program, we got three chairpersons. I'll be inviting them on a dais, please. Dr. Anju Turiya, Dr. Amita Sinha, Dr. Madhu Sinha. And I'll be displaying your profile also. स्लाइड पीछे जाइए. पीछे जाइए पीछे. बस. All right, can I request the chairperson to please invite the speaker?
Good evening to everyone. Hearty welcome to all of you, and it's my honor and privilege to chair the session. I extend my hearty welcome to our guest speaker, Dr. Baru. Sir, please, CB sir, please put your CB or Dr. Baru. Yeah. Dr. Arun Kumar Madhavan Baruha, and he's a great academician and great, excellent orator. So welcome to this oration.
Good evening, ma'am. As we come to the end of the day 2 of the Labourcon, before I make my presentation, I must offer my thanks to the whole organizing team, ably led by Alka, Vinita, and everyone, those who have joined hands to see the light of the day. A lot of things have been covered up in my previous sessions in a recurrent pregnancy loss, but we all know that thromboprophylaxis in pregnancy continues to create, think, and also evolve ourselves when we land up in issues. Being a postgraduate, we are very comfortable in knowing this, that pregnancy is a prothrombotic condition. We all know the Werker's triad, which consists of all these conditions, and ultimately they all exist in the condition where we have specialized in, that is obstetrics. We also remember that thromboembolism is the most common cause of direct death, especially related to maternal death in developed countries. Out here, we do not do so because we have very poor infrastructure of diagnosis. But if I'm being allowed to add, on 1,000 continuous autopsies being carried out in a postgraduate institute of Chandigarh, 74% were attributed to thromboembolism. So, until and unless we execute the whole procedure, we will not be able to show, and we say, ऊपर वाला ने जो होना था हो गया, हम लोग कभी कुछ कर नहीं सकते हैं. So injury in obstetrics can be both during abdominal and vaginal delivery, so it's quite common. So then why do you need to do thromboprophylaxis? High prevalence of venous thromboembolism and the clinically silent nature of the disease is important, and as I said, this is a preventable condition to the tune of around 80 to 90%, and this dictum is not my dictum, it has been an age-old dictum since Craigett and Salzman published their papers in 1979. When we apply the broadness of the effective method of prophylaxis, we see a high success rate and prevent this particular condition. We know venous thromboembolism is one of the most common causes of maternal morbidity, and when we have a molecule which can really prevent this, we know we have a list of drugs that are available in them, but thank you, sir. Thank you for being present. When we have a whole list of medications being available to all of us, I think it's a duty of every OB/GYN consultant who is dealing with the healthcare to master at least one of them. And I must admit that I have mastered about LMWH, because if I know this molecule thoroughly, I'll be able to prevent quite a bit of thromboembolic phenomena and thereby prevent maternal death that could be a sequelae. Several recommendations concerned how to identify women at high risk. I'm not going to tackle how to identify the risk factors because the time is very short. Risk assessment itself is very important, and if you follow the government of India's risk stratification for every antenatal mother, there itself we have ample data to produce and to detect and also to identify who falls in the category. When should we start thromboprophylaxis is a big question, and if we can start it early, the benefit is bound to come early. So your knowledge of risk stratification is very important. In some cases, as you say, suppose the patient in early pregnancy comes with hyperemesis. Those patients also have a probability of developing thromboembolic phenomena. So in those, if we start thromboprophylaxis for a short duration and just stop the termination procedure when the patient recovers, we do get good benefit. In some cases, we might have to continue till 28 weeks. In some, we might have to start at 28 weeks. So it's totally purely knowledgeable based conditions. Today, we see quite a bit of pregnancies coming from the ART population, and hyperstimulation, IVF all contribute to enhanced rate of thromboprophylaxis, and that's why all ART consultants start thromboprophylaxis in anticipation way ahead. When should we interrupt for delivery? Yes, we must stop this when you see vaginal bleeding or when the labor begins, because as I said, the injury itself should not be added upon by continuing thromboprophylaxis during that period of time. Moreover, when the patient is taken up for C-section, or if a patient is on continuous low molecular weight heparin, we need to stop this particular doses the day before or at least 24 hours before the procedure. Now, if a woman develops a hemorrhagic problem while on a low molecular weight heparin, the treatment should be stopped and expert hematological advice being sought, because yes, it is possible that in patients who are with LMW or without LMW, they might have even subchorionic bleeding. So whether to continue with this or we should stop this, it's barely $1 billion condition, but we need to get in consultation from our hematological colleague as well. So, of the agents that are available in front of you, quite a bit are being utilized across by anyone and everyone. But what I feel, if you can at least select one, the one that is freely available across the nook and corner of the country, one that is cheapest, and one that you can give to your patient without much of a monitoring, should be the ideal one, and that's why low molecular weight heparin continues to rule this particular world of thromboprophylaxis even today. But remember, warfarin can be switched over immediately once the delivery is over, and remembering always that warfarin remains a contraindicated medication while on pregnancy. The dosage regime are all that we need to know. I'm not going to take it line by line. Just throwing some light on unfractionated heparin, we have used that molecule quite a bit till low molecular weight heparin was available, but that's when you use this, patients need to be under monitoring. Denoperoid is one, fondaparinux is one, warfarin can be switched over once the delivery has been completed because it is considered quite safe in breastfeeding. Remember, this is contraindicated. Mostly we think that aspirin is being used for thromboprophylaxis. It's not. Aspirin should not be recommended for thromboprophylaxis in any of the patients. We use a lot of high molecular weight dextran for treating different conditions. That should also be switched off when you think of thromboprophylaxis or when you have this high risk data population that you are treating. One of the simplest ways that if it is available is anti-embolism stocking. It is not costly. It can be kept in high risk pregnancy centers and they can help quite a bit without taking the pricks. Yes, if you use it in optimum time, if the venous pressures can be sustained to around 14 to 15 millimeter of mercury, they could do a very good job. Risk assessment of venous thromboembolism is the whole crunch of your taking and selecting the patient. If you have a total score of more than equal to 4 antenatally, we must start thromboprophylaxis from the day you have detected the risk scoring. If the score is 3 antenatally, consider thromboprophylaxis from 28 weeks onwards. If the risk score is 2, you should give it postnatally. And if admitted to the hospital antenatally, the patient must be on thromboprophylaxis with a total score of 4. Now, what are these scores for? If there is a history of previous venous thromboembolism, except a single event related to a major surgery, the score itself is 4, and with that score, that patient, when she becomes pregnant, she comes automatically into the criteria of thromboprophylaxis. Previous venous thromboembolism provoked by major surgery comes under 3. Similarly, the whole list, age, obesity, smoking, are all factors that we often ignore, but they do play a very important role into the risk stratification of this group of patients. The common one that we all need to know, cesarean section in labor has a little higher risk factors in comparison to the normal labor. So, risk scoring remains a very important criteria. If a patient has developed ovarian hyperstimulation syndrome during the infertility workup or during your stimulation protocol, yes, please remember that if the patient conceives whenever the embryo transfer is done, that patient need to continue that particular thromboprophylaxis throughout the pregnancy. In the summer season, dehydration itself with compound venous stasis in pregnancy can lead to thromboembolism. Remember, this particular diagram will explain anything and everything. This is already in the website. We don't need to recapitulate it. Those who are interested in the program can think of high risk, intermediate risk, and the low risk. They are in the website of the Royal College of OBGYN, and they play an immense helpful role in understanding the condition. And if we can master them, I'm sure we are going to do quite a good to our class of patients. Now, we have used the molecule. We need to know when not to use the molecule. Known bleeding disorders like hemophilia, von Willebrand disease, or acquired coagulopathy. Remember, we do not screen for these rare conditions on a routine basis. Active antenatal or postpartum hemorrhage. Women considered at increased risk of major hemorrhage like placenta previa, and thrombocytopenia when the platelet counts goes below 75,000. Acute stroke, severe renal disease, severe liver disease, which has become very common with the use of progesterone right and left in the first trimester, uncontrolled hypertension along with preeclampsias and toxemias, they all contribute to be little contraindication because balancing this molecule plays a very important role. Still, we have a very dark hole in the whole subject. Lot of research avenues remain wide open. Those of you who would like to venture into this are doses of low molecular weight required in obese, pregnant, and a puerperal woman is totally not clarified. At present, it is unclear whether women undergoing surgical management of miscarriage and surgical termination of pregnancy are at increased risk of venous thromboembolism. How do risk factors of venous thromboembolism interact in the antenatal and postpartum periods are not clearly defined till now. How do you reduce or avoid the prevalence of risk factors for venous thromboembolism, and should thromboprophylaxis vary with different heritable thrombophilias are yet not answered in the literature. As I said, they're all available in the Royal College of Obstetrics and Gynecology's website. But one of the most important things that I feel when you are prescribing this particular molecule to your patient, if you are looking at the success, I think proper weight of taking the injection needs to be suggested. And people when trust on you, I think it's our duty to recommend and submit a video of this nature to every patient. I'm done. So this will hardly take a few seconds to transfer in a WhatsApp, but taking the injection in the right site, in the right way, will give the right result and thereby prevent a lot of complications that are coming in our way. Just let us see the video, otherwise it'll just take few seconds. Holding the skin flap, lifting it up, putting it in a 90-degree is most important. We know our women are very much afraid of taking injections, but once these are being shown, they are effective, the results obtained, they will pass on the information to the next group of patients. Thank you so much for patient hearing, and thank you so much, Madam Chairperson.
Mic is not on. Switch on the mic, please. the long press.
Ansuman, for such a nice presentation. You have discussed all the aspects of venous thromboprophylaxis, when to given, to whom it was given, and to whom it was indicated, contraindicated. Thank you so much again. Again, congratulations to you. And our next guest speaker, Dr. Ansuman, and Dr. That is by Dr. Ansuman.
Yep. No, we're just doing a quick check.
Welcome, Dr. Ansuman.
Just doing a quick check if Dr. Anshuman is here. I think he has not been able to make it. If not,
Dr.
then we will conclude the session.
Yeah, Dr. Himanshu,
That's
next
fine. Dr. Arup, please come on stage for a quick picture since we have some time. Can I request both the chairperson to come in the center? All right, after this, we are coming up with the Mahabharat. We call it as a Mahabharat. Yes, it's going to be a debate. This is what I learned in my last few conferences at Patna. There'll be two speakers and they'll be talking for and against. And we got our very senior and skilled doctors with us who gonna do the role of judges. Can I please invite Dr. Neeru Goyal as our first judge, Dr. Usha Kumari and Dr. Himanshu Roy. Dr. Neeru Goyal, Dr. Usha Kumari and Dr. Himanshu Roy. Please. And we got two topics where there'll be individually there'll be two speakers, one for, one for against. So first, for the first topic we have Dr. Mukta Agrawal, and for the against we have Dr. Charu Modi. Please remember, as a speaker you will get 6 minutes. We'll give 2 minutes to judges if they have any questions. And then this is how the debate will continue. Dr. Neeru Goyal, please join us. Dr. Manshura, if with your permission, can I invite the first speaker? Yeah, both the judges. All right. For the first topic and for, I'm inviting Dr. Mukta Agrawal.
Good afternoon, respected chairpersons. And today I am speaking for the motion cesarean section on maternal request. So here is a question. A 25-year-old pregnant woman, 39 weeks, fetus is apparently normal, healthy, cephalic, and despite being informed that a vaginal delivery is indicated, and women insist on cesarean section. So what will be your honest take with the rationale? Think for a minute. So this was a question which was taken in the Europe study for comparing the attitudes of obstetrician in 8 European countries, and the result is 79% of UK doctors agreed to go cesarean section for this patient. In the background, prophylactic cesarean is the term which was used to avoid the risk linked to the anticipation of vaginal deliveries in 1985. And imagine just in 1 decade, survey showed that 31% of obstetricians have chosen cesarean section for themselves only. But we actually, accurate figures are lacking because it is neither a well-defined clinical entity nor is coded. All the guidelines worldwide favors CDMR except SOGC. So this is a busy slide, but this is just that moderate quality evidence says that cesarean section decreases the occurrence of PPH and hospital stays shorter in vaginal birth. Rest for all quality of evidence is very poor. So while taking a decision for cesarean section, there are two premises. One is the factual premise. It's the reported attitude that what actually a person do in that particular scenario, and other are value premises, which includes autonomy, beneficence, and justice. So together these two actually are utilized to derive conclusion whether to go for it or not. So when we go on ethics, there are three principles: beneficence, autonomy, and justice. For us, we have three clients: the patient, obviously, the fetus, and the physician. If we talk about beneficence, if we take any decision against the will of the mother, it could negatively affect her experience and her relationship with us. And fetus is relatively safe, and we are not doing any harm for the fetus by doing CDMR. It's for the physician, there is a lack of agreement whether it applied to the physician or not, because complications may happen if CDMR is denied, and we may face legal consequences. As far as autonomy is concerned, principle of autonomy prevails and is assigned highest priority for the mother, and mother should be adequately informed for all the things before taking any decision. Fetus, as it is not capable of taking any decision, so the principle of autonomy does not apply to the fetus. For a physician, it's again a debatable thing, but if in case of disagreement, physician's autonomy and professional integrity, you can always have a right to reject the patient's request. So principle of autonomy prevails, seek the guidance of patient and her right to accept or reject any treatment offered. If we talk about justice, complications may happen in instances where CDMR is denied, and then we may face legal consequences, and it is the fear of legal consequences was the foremost factor which helped in the decision making in the studies. So now there are two conflicting prepositions: women's self-decision making. She has all right to determine the treatment for herself, and the medical utility, that is to optimally use the resources. So there is a study which says that what is the perspective of CDMR for gynecologists, lawyers, and patient. Patient consider it as therapeutic, and they say that if it's not being done, they may sue their gynecologist. While doctor consider it as a mistake if it is being done, and lawyer considered it as an important intervention to meet patient's indication. I would like to have your attention in this particular slide. There are two terms: safe obstetrics and defensive obstetrics. Safe obstetrics is an ideal situation where we have the best thing in the best interest of mother and baby. While in defensive obstetrics, which is often referred to as obstetrician distress syndrome or 4 PM syndrome, where we actually medical actions are performed to refrain being sued or for those things. But mind you, CDMR is not the defensive obstetrics, because you are not making any indication. You are telling the equal indications, the risk and benefits of vaginal delivery and cesarean section. And this is the patient who is choosing the treatment for herself. So CDMR is a safe obstetrics with a right to autonomy for the patient. So there are few facts from literature review, systemic review, NIH, which has almost more than 1400 articles, and it says that there is no quality of evidence to favor CDMR or vaginal birth. Even gynecologists prefer cesarean section for themselves and their wives, and high socioeconomic status, educated women, they are more likely to opt for cesarean section. To summarize, spontaneous vaginal delivery is the safest option but cannot be predicted. Benefit of elective cesarean section appears to equal to vaginal delivery, and more risks are linked to primary indication or emergency nature of the cesarean section. Available data and a systemic review does not provide any basis for favoring either mode of delivery. We need further research to provide direct evidence to facilitate patient counseling.
Time is up.
Yeah, just one slide more. Prospective cohort study and database studies are needed. Last slide. Thank you for your patient hearing.
Just you have 2 minutes to discuss with her if you have anything to ask.
No, I think first she should speak and then they can counter question each other.
Please invite the next speaker.
Yeah, Dr. Charu Modi will be speaking against cesarean section on maternal request. Time given is 6 minutes. And after that, they can counter question each other.
Respected chairpersons and members of the August gathering, a very good evening to all of you. I am going to speak against the motion. Yeah, as we can see, it's very clear from the graph that there's a rising cesarean trend across the whole globe, and the whole bodies, the national and international bodies, are really concerned about the rising cesarean trends. The WHO also is very much concerned and has quoted that rising rates suggest increasing numbers of medically unnecessary and potentially harmful procedures. But it has also said that not all cesarean sections carried out at the moment are needed for medical reasons. Unnecessary surgical procedures can be harmful both for mother and the baby. Now, dear opponent, I would like to highlight I would like to take your concern over this slide. If we are going to continue with our rising trend of cesarean sections, then what will happen to our SDG goals? The whole world is having hue and cry about that to bring down these maternal mortality rates and bring down these cesarean rates. Think over it, please. Now, I totally agree with you that there are genuine indications, medical indications for maternal and fetal conditions where one resorts to a cesarean section. But simultaneously, there's an increased rise in cesarean section on maternal request, as you said, and it is adding fuel to the fire. Now, possible reasons for CDMR can be fear of pain during delivery, previous birth experience, pelvic organ prolapse or incontinence, and future decreased sexuality needing for cesarean section and potential harm to the baby. Then one more important point is control and convenience, both on the part of a doctor, the care provider, as well as the patient. Because nowadays we see there's a rising trend of doctors working in various corporate hospitals or going to various private nursing homes. They don't have time. They they have to plan their routine, they have to plan their delivery. So they are also opting for CDMR on the slightest request of the patient, or they find that slightest change in the process of normal delivery. Of course, the patient finds it convenient because she can plan her routine, she can plan her dates or jobs according to her schedule. And nowadays, this fancy term is there, which is too posh to push. In the sense that the higher society is aping these Bollywood or Hollywood stars who have resorted to CDMR. So one more thing I would like to highlight is that is the rising CDMR because of premium pregnancy? Because a lady is not conceiving for several years and now she has conceived either naturally or by infertility treatment, and we label that pregnancy as a precious pregnancy or a premium pregnancy. So my question is, are pregnancies occurring naturally are not precious? Are they not premium pregnancies? I think we should consider each pregnancy to be precious and premium. Now, I would like to highlight about this point that fear of labor pain resorts a patient for CDMR. So my counterpoint is that we have to make such arrangement, or we have to give that environment to the patient where she feels comfortable. We have to have some antenatal counseling sessions where childbirthing videos or lectures are given to patient to allay her anxiety. Then avoidance of labor pain can be with the use of epidural analgesia as well. Then there's again a risk of postpartum pregnancy on which CDMR is resorted. So I would like to highlight that induction of labor may be a reasonable alternative to CDMR, and careful assessment and monitoring of pregnancies beyond 41 weeks has to be resorted to. There's also as one may say that there is a decreased risk of PPH, but mind you, even cesarean section per se is a surgery which has a lot of amount of bleeding, around 500 to 1000, and God forbid if PPH occurs, then what to say. Then related emergency complications or related risk, decreased risk. Then again my counterpoint is that if at all we avoid surgery, then all these complications are avoided. Lowering the overall cesarean rates would lower the risk of rates of all cesarean section related complications. Then you said about patient autonomy. I would like to say that the issues are far more complex than the words just choice or request of the patient, because informed consent may be biased, and no studies have systematically examined the information provided to informed consent, and evidence itself is lacking to support equivalent safety. Some argue that if the risk or benefit of CDMR and vaginal births were truly equal, then all women should be counseled for both as viable options. So this was a very important point. Then we all know what are the risks associated with the cesarean section. There are various maternal risks like increased morbidity, longer hospital stay, longer increased financial burden. Then bowel or other visceral injuries can occur, and there can be chronic pain also. Long-term consequences can be decreased fertility or miscarriages. Just 2-3 slides more, please. Then there is difficulty or delayed in breastfeeding and increased risk of childhood asthma as well. We all know that neonatal risks are also going side by side with cesarean section. Like there is increased risk of respiratory morbidity in the children, then mechanical ventilation may be required, sepsis or hypoglycemia can occur, and NICU admission rate is also increased. Now let's see what do various professional organizations say about CDMR. The FIGO found CDMR to be unethical. Even the ACOG supported informed consent though, but it also believes that an obstetrician should not perform the procedure if they do not feel it is in the patient's best interest. SOGC also supports vaginal birth as the preferred method of delivery. Now, maternal request for cesarean delivery is a surgical indication that is not clearly defined and is probably a result of inadequate information or misinterpretation of the options available, and in some cases is the result of coercion based on the preference of the providers and institutions that find spontaneous vaginal delivery a major convenience. Even women who plan several children should be advised against CDMR because of the increased risk of placenta previa, accreta, and stillbirth, and of course uterine rupture in subsequent pregnancies. So to conclude, cesarean section on maternal request is not a well-recognized clinical entity, dear opponent. Anxiety, fear, and previous childbirth experience should be addressed by prenatal childbirth education and emotional support in labor, and larger interest of the patient has to be looked upon, and all efforts should be made to reduce the fetal and maternal mortality and morbidity. Even the national and international bodies also did not approve of CDMR, and in the absence of medical indications for cesarean section, plan for vaginal delivery is safe and appropriate and should be recommended. So in my view, cesarean section on maternal request is not only unnecessary, unwanted for, but is also unethical. Thank you very much for the patient hearing.
Yeah, Dr. Mukta, would you like to ask Dr. Charu any question?
Obstetric pregnancy and childbirth is a physiological phenomena, and for that your pregnant patient is not your patient, she is your client. So she has all the rights to choose her mode of delivery. If I agree that this should not be biased, your counseling should not be biased. You should tell her all the risk, benefit. If she has fear or anxiety, maybe tocophobia, that is fear of labor pain, or she has some bad past experience, then you should always counsel, but doctor should not behave like God. Now today, this is an era of shared decision making, evidence-based medicine, and informed choice. And forget about conducting a vaginal birth. Against her will, you even cannot put a cannula to any patient if she is not agreeing. So yes, even I do not want that you should do cesarean section left and right. You are biased, you are making invalid indications. But even after a proper counseling, if she does not want to go for a normal delivery, then it should not be forced or imposed to her. And literature says that this CDR, request for cesarean delivery, is very much among the educated people, among the gynecologists, obstetricians. So you can't really, they are all well informed. And if we see our own practice, just go back in the past 1 month that how many cesarean delivery requests you have done for your medico colleagues. And the answer is for everyone, it's in the heart. I agree that we should control the cesarean section rate, but it should not be in the cost of patient's autonomy, or because at times, even if you are conducting a delivery beyond her will, and she lands up in cesarean section or neonatal this thing, then consequences will be borne by the obstetrician herself. Thank you.
Dr. Charu, would you like to answer a question?
Yes, sir. As Dr. Gupta has said that all the patients are informed, they would still like to have this thing, CDMR. But I would like to ask her that how many times or how many sessions do we have? Because I already told in my presentation that it's they have this unset fear of childbirth or their previous birthing experience, or they have listened from some other friends of theirs, which the information may not be true. So we need to have those sessions, or we need to give them that type of counseling, where we can put the facts that instead of going for cesarean section when there is no genuine indication for medical reason, you can very well have a vaginal delivery and give her that kind of support and emotional support, and as well as awareness and education about the vaginal birth when she can easily have one.
Dr. Neeru ma'am, your final verdict.
This is a difficult debate. We cannot settle it. Both the participants have put up their points so well, and we are facing this dilemma every day. We talk about idealism, vaginal delivery, but we don't have time for that much of counseling. And we might do some counseling and that dedicated counseling for 1, 2, 3 patients. But spending that much of time for counseling is actually not possible in our setup, and somehow the patients come with a determination, करना है तो करना है, आप उसको मना नहीं कर सकते हो, और उसके consequences तो फिर obstetrician के ही होने वाले हैं.
That's what.
तो इसलिए मतलब ठीक है, idealism is vaginal delivery, but we have to see what is practical and take the decision accordingly. So both of you have put your points very well.
Thank you, Chairperson.
चलो opinion अभी फिर pass होगा कल.
Opinion from the house.
If anybody has any comment about this thing, strong, some.
Dr. Tulika ma'am. How many will go for CDMR? That was my first question. It's the day-to-day difficulty we are facing. And we actually go for our own people.
Okay, judges.
Thank you so much.
Thank you. Let's have a round of applause for them, please. All of you. Thank you. For the next topic, we'll be inviting.
The next topic is expectant management or induction. And the first speaker speaking for the motion is Dr. Bhavna Tiwari. Dr. Bhavna Tiwari, please.
Thank you, sir. At the very outset, I would wish a very warm good evening to my respected judges, Neeru ma'am and Himanshu sir, and the respected audience. So today's second topic is expectant management or induction at 40 weeks, and I am for expectant management. So expectant management is the standard of care because Mother Nature knows the best. So points to ponder are, is elective induction of labor safe? Is it feasible as well as cost effective, especially in low middle income countries like ours? I'll be quoting the studies supporting expectant management. what the guideline says on this topic, and finally the conclusion. Expectant management involves non-intervention at any particular point of time and allows the pregnancy to progress to a future gestational age. And majority of the studies state that elective induction should be reserved only for certain indication, that too explaining the risk and taking a proper informed consent. What are the cons of IOL? Maternal, like hyperstimulation, failed induction, prolonged labor, cord prolapse, abruption, infection, PPH, emotional fear and anxiety, close fetal heart rate monitoring requiring more and more of staff, and restricted movement. And these are the probable benefits of expectant. Coming to fetal, iatrogenic prematurity, distress, birth injuries, hyperbilirubinemia, increased nursery admissions, and in turn all leading to increased sepsis. Now these are the evidence-based pros of expectant management, like less potential for failed induction and thus cesarean, less need for medicalization, mature baby and its HPA access will initiate parturition cascade, leading to less chances of iatrogenic prematurity, less time spent in labor, less PV, so less infection, and definitely the cognitive benefits for babies during a continued pregnancy beyond 40 weeks have been proven to be increased. Now coming to certain studies which was done to see whether it is a sustainable option in low middle income countries. So this was a study published in 2019 in Case Reports of Women Health, and they concluded that healthcare infrastructure and manpower in low middle income countries needs to be improved if you are planning for induction routinely at 40 or 39 weeks, and reduced bed strength increases the waiting period for elective induction. Another similar study was done which was published in 2013, and WHO recommended that NICU admission in Africa and maternal ICU admissions in Asia were significantly higher when you are following elective inductions, which may have its own resource implications. So coming to effect on country's economy, the uptake of routine inductions at 40 weeks could impact hospital resource availability, healthcare costs. It will increase government expenditure on midwifery, and if induction at 40 weeks are to be made routine, adoption of these protocols would require more and more of hospital staffing as well as resources, a point to be considered especially in our setting. So let labor begin on its own. Spontaneity has its own time and its place. So studies supporting expectant management, this was a systematic review published in 2009 in evidence report, and it concluded that when induction was done beyond 41 weeks, there was decreased chances of both meconium stain liquor as well as cesarean section. Similar systematic review was published in Annals of Internal Medicine in 2009, which concluded the same, less cesarean, less meconium stain liquor if you induce beyond 41 weeks. Coming to this population-based cohort study, recently published in 2021 in Acta Obstetrics Gynecology Scandinavia, this also says that if you do non-medically indicated inductions earlier, that is around 37, 38, 39 weeks, it will be associated with increased odds of cesarean than when you time it beyond 40 weeks. This journal was published in 2022, and this also supports the same and says that elective induction is associated with higher cesarean rates, and also that further research is needed before you implement clinical practice changes to encourage more and more of induction in routine practices. This was a recent Sri Lankan study published in 2020 which showed that induction at any point of time, be it 40 weeks or 41 weeks, is associated with more and more of maternal and neonatal complications. This was an Indian study published recently in 2023 which compared expectant management and said that if you wait for expectant beyond 40 weeks, more and more women will go into spontaneous labor, and cesarean section rates were also seen to be less in the expectant management group as compared to the induction group. This was an interesting study I came across which was published in Journal of Women and Birth, and it said there are variations in the preferences and motivations among the females, and so this suggests that there is a room for shared decision making in management of late term pregnancy. Now what the guidelines have to say: RCOG nice, go for induction between 41 to 42, WHO insufficient evidence for inducing before 41 weeks, SOGC Queensland 41 to 42 weeks. So to summarize, several qualitative systematic reviews concluded that majority of women feared medical interventions and prefer a physiological birth, promoting their physical and psychosocial capacities. And majority of guidelines say that small reduction in cesarean in arrived trial does not justify interference into the natural process of pregnancy, labor and birth. So to conclude, go for shared decision making. Use of routine induction at 40 weeks is completely unjustified. Hospitals, especially in our country, not yet resourced to support routine elective induction, and hence expectant management should be the standard of care. Thank you.
Speaking against the motion is Dr. Poshali Sanyal. So Dr. Poshali Sanyal, please.
Good evening, respected chairpersons, friends and colleagues and my seniors and my worthy but slightly confused opponent. First of all, why are we having this debate? What is the crux of the matter? We are discussing about expectant management at 40 weeks versus induction, not expectant management versus induction at 37 or 38 weeks. Because we want a healthy baby for a healthy mother, and we are concerned among the rising cesarean section rates, and we want a vaginal delivery. So, 40 weeks and beyond means a mother is post-dated. And what are the problems of the post-dated pregnancy? My worthy opponent was talking about NICE. What does NICE have to say about post-dated pregnancy? That it has increased risk to the mother and increased risk to the baby. Because there is increased risk of postpartum hemorrhage in the mother, and the main risk to the baby is stillbirth, then post-maturity, macrosomia, oligohydramnios, meconium aspiration, all of which lead to stillbirth. It is an enormous but yet overlooked tragedy, and more than 5,000 women and their families are experiencing a tragic loss of a baby every day. Look at this graph that explains it all. Why are we talking about induction? Because from 40 weeks you can see that perinatal deaths per 1,000 ongoing pregnancies keeps increasing, and for every one more week of pregnancy which is increased by expectant management, the rate of stillbirth also keeps rising. So how are you going to explain to the mother at 40 weeks that okay, I will give you expectant management, but yes, there is also a risk of stillbirth? Now this is the age of litigations, and when the woman walks into the chamber, she is full of queries, a lot of queries. So when you tell her that okay, there is a risk of stillbirth, this percentage, she says, doctor, I want a healthy baby. Because the aim is a smile on the face of the doctor and the smile on the face of the mother and her families. My worthy opponent was talking about NICE. What does the new recent guidance on induction of labor that has been updated in 2021 have to say about induction? It is said that the risks associated when a pregnancy is continued beyond 41 weeks is that there is increased likelihood of cesarean birth, there is increased likelihood of the baby needing admission to the NICU, and there is increased likelihood of stillbirth and neonatal death. So NICE says you discuss with the women that induction of labor from 41 weeks may reduce these risks. So actually NICE is propagating induction of labor and not expectant management. As I said, a pregnant mother walks into a chamber with a lot of queries. When you're propagating expectant management, her questions are, when will I deliver? How will I deliver? And will my baby be safe? So you have to answer all her queries, because with induction of labor, the clock starts ticking. She needs to deliver, but it is for the benefit of the mother. She has a coordinated care plan. She knows that fine, I will try for vaginal birth and I know when I will be delivered. Next, who monitors the mother in case of an expected management? In the UK and in the US, the mother gets one-to-one care from a trained midwife. But India is a land of the 135 crore population. How will the mother be monitored? The healthcare system is stretched. My worthy opponent was talking about costs. Are not the costs and problems on the healthcare staff increased when you are doing expectant management for the mother? Because you have to monitor her. You have to do CTGs, you need to do ultrasounds. Who will monitor it? The ASHA workers are not monitoring the mother. And this poor lady is left to do her household chores, manage her other babies, and she does not even know when the baby has stopped moving in her womb. And that, ladies and gentlemen, also increases healthcare costs, because stillbirth increases healthcare costs on the country. Again, as I said, tests to determine fetal well-being. Who will do them? You can see this huge line in the hospital. You are not admitting the patient for induction of labor, but you are actually increasing the stress on the obstetrician Who is going to monitor these mothers for expectant management? She doesn't even know when they are going to go into labor, and the healthcare staff is at their wits' end. Next, we come to the concept of the working mother, who has to manage a maternity leave from her boss. Now, if her boss at 40 weeks gets to know that this mother she doesn't know the expected date of delivery, he will say, you work from home. And again, her blood pressure starts rising. So all the complications start rising. Now, my worthy opponent was saying, you're talking about social obstetrics. Where's your evidence? Well, let's come to the ARRIVE trial, which she was talking about. The ARRIVE trial was basically published in the New England Journal of Medicine. It was a randomized trial balancing and comparing induction of labor versus expectant management, and the main findings of the ARRIVAL trial was that cesarean delivery rate significantly decreased after this trial was published. Also, my worthy opponent was talking about adverse neonatal outcomes. ARRIVE trial pointed out that mothers who underwent induction of labor, actually their babies had less numbers of neonatal admission, there were less amount of neonatal seizures, there was less surfactant use, and for mothers there was less need of blood transfusion. So the ARRIVE trial actually propagates induction of labor. Also, the index trial from Netherlands, the SWEPIS trial from Sweden, all those countries which propagate vaginal birth have actually found out that induction of labor leads to a lower rate of stillbirth. There is no increase in the cesarean section rate in the induction group. Also, there are fewer amounts of perinatal deaths. Now, it is also said that induction of labor is beneficial in complicated pregnancies like gestational diabetes mellitus as well as the elderly primigravida. So, I would like to conclude by saying that induction of labor is not increasing cesarean section rates. It is actually propagating vaginal birth. If you are planning to decrease cesarean rates and go for vaginal birth, train the mother for antenatal classes. Don't decrease the number of induction of labors. Thank you.
Yes, Dr. Bhavna will counter her opponent.
Thank you, sir, for giving me this opportunity to do the rebuttal. First of all, the entire definition which she mentioned about the complications related to post-dated pregnancy, the post-dated pregnancy is actually 42 weeks beyond. Post-term is 40 weeks beyond, and 40 weeks beyond, the complication has still not increased beyond, until 41 weeks, as the graph says. Then she was mentioning again and again about NICE guidelines. NICE guidelines definitely says about induction, but that is beyond 41 weeks. It says 41 to 42 weeks, SOGC 41 to 42 weeks, Queensland 41 to 42 weeks, WHO 40. So if so many bodies are recommending about induction beyond 41 weeks, our debate was at 40 weeks, and at 40 weeks completely no for induction of labor. Then she mentioned about the ARRIVE trial. The entire selection of the control population in the ARRIVE trial was wrong. The ARRIVE trial selected, most of the patients were obese in the group, so that does not mean it is uncomplicated pregnancy, because obesity itself has its own problems related to obstetrics, and cesarean section is bound to increase in such cases. Patient selection was not proper in ARRIVE trial. There was Hawthorne effect, or the observer effect, which we commonly call, which was seen in ARRIVE trial. That is, the patient or the party, the clinician, they have the tendency to over-report the results just to have the effect. There was lack of blinding in the ARRIVE trial. So just on the basis of ARRIVE trial, you cannot recommend routine induction at 39 and 40 weeks. And as far as the cost goes, cost of monitoring is still lesser as compared to the cost of admitting a patient, keeping in patient, where we have our bed crunch. Most of madam is also working in IGIMS Government Institute. We know the bed crunch we have, the problems we are facing, the price the patient has to pay. If we don't have doctors to monitor, how can we monitor the patient during labor? So that is completely uncalled for, that we induce each and every uncomplicated pregnancies as 40 weeks. But yes, I have already mentioned that the patients have their own preferences, they have their own motivation, just like the previous debate was going on about. So we have to go for a proper discussion with the patient at 40 weeks, that these are the two options, this is the pros and cons of both the options, and then we should go for shared decision. This is my ultimate statement. Thank you.
Thank you, Dr. Bhavna. I think Dr. Bhavna has slightly confused the term induction of labor. Induction of labor does not always require hospital admission, because there is something called a membrane sweep, which you can do and you can send the patient home. Once again her pains start, you can then admit, and there are other ways like the prostaglandin gel, which you can give, and induction of labor does not always mean a hospitalization. Second, you were talking about shared decision making. Nowadays, the term is my body, my choice. So the woman at 40 weeks who walks into your clinic, now you tell me how many of them with this talk of my body, my choice will be convinced that, okay, I'm going to give you expectant management, you may deliver, you may not deliver, and then she will say that I don't know when I'm going to deliver. What is the point of giving an expectant management if at 42 weeks you tell me that you have not gone into labor and I'm going to do a cesarean section, and after the delivery, due to less amount of LICA, my baby goes into the NICU. What do we want in modern obstetrics? We want a healthy mother, we want a healthy baby, and also we want less harassment on us, the obstetricians, because this is the age of litigations. Gone are those days when you just, then the mother and her relatives would be convinced by whatever you would be saying. Today, she is the main person. There is shared decision making, but ultimately it is her body, it is her choice. So, induction is a more rational decision, because no mother at the end of 42 weeks will go away with a stillbirth. You are bound to face litigations, and complications are bound to be there, because all she wants when she walks into your clinic is that she goes home with a healthy baby. Thank
you. Dr. Neeru, because I've stopped doing obstetrics, so Dr. Neeru, being head of the Department of IGMS, will be a proper person to give the final verdict.
Actually, my decision will be biased because what I think, and the debate whose thoughts coincide with me will win the debate, sort of. So my thoughts are that we should not induce labor at 38, 39 weeks, and definitely not before 40 weeks. And in my unit, I try to say that wait. Just keep on monitoring the fetal movement count, and if you have any problem, you can report to hospital. Because of all these litigations going on, and we are always afraid in the back of our mind what will happen, and therefore we start interfering. And this interfering has no limit. In our hospital, we see that inductions are going on at, it starts at 39, then someone will do at 38, then you suddenly see, someone is inducing at 32, 34, 33 weeks, and for small reasons, minor reasons. And there is no end to induction of labor unless you put a stop to it. And it is wrong to say that induction of labor does not increase the cesarean section. It definitely increases the cesarean section. We are working in a setup where anesthesia has improved, and we ourselves start thinking that anesthesia complications nahi hai, cesarean ke complications nahi hai. But there are definitely complications of anesthesia also and cesarean also. And at the end of the day, anesthetists refuse to accept that complication was because of anesthesia. It falls on the obstetrician's head. And suppose India में तो अभी वैसा वाला audit नहीं होता है कि आपने cesarean किया क्यों, क्योंकि पैसे patient खर्च कर रहा है. अभी gradually जब government will start auditing this thing कि खर्चा क्यों हो रहा है, cesarean क्यों हो रहा है JSSK में, जब सब कुछ free है, थोड़े दिन में definitely audit शुरू होगा. और जब ये बात होगी कि खर्चा क्यों हो रहा है, वहाँ की तरह कि आप not indicated तो आप hysterectomy नहीं कर सकते, not indicated तो आप cesarean नहीं कर सकते, तो we are not very far off from those things. तो जब यहाँ पे होगा, तो फिर जब problems होंगी तो होगा कि आपने unindicated induction क्यों किया, आपने unindicated cesarean क्यों किया. So there is no end to these things. So it is better that we stick to the recommendations by various bodies and follow that, then we are safer also. And जो आप कह रहे हो कि मैन पावर चाहिए, तो मैन पावर तो जब आप इंड्यूस करोगे तो ज़्यादा चाहिए. अगर आप स्पॉन्टेनियस के लिए वेट करोगे तो कम मैन पावर की ज़रूरत है. तो इट इज़ बेटर टू वेट एंड वॉच. Don't induce means everyone at 39, 40, 38 weeks. And definitely not before 40 weeks, and maybe wait for 3, 4, 5 days. It will definitely make a difference. And try to calculate the dates. That will change your management. And always check the dates 2 times, 3 times. Because your junior may have calculated, and once you check the dates, you feel नहीं, अरे अभी तो 36 हुआ है, 40 की तो बात छोड़ दो. तो that is one. Thank you.
Yes, ma'am.
Yeah, just use this mic, I said, ma'am. Okay.
I want to really say one thing. I love the topics of the debate, so I can especially, I was sorry that I missed your talk a little bit. But actually the dilemmas of the obstetricians have been addressed in both the topics. So first of all, we go to the scientific chair, whoever came. And then I want to say all four debaters were so good.
You know, from where you are saying, it's very right, but I would also like to say that we as obstetricians, and in this stage and age, like if it's a primary, I mean, एक टाइम था कि हम 37 वीक्स में pelvic assessment करते थे, पर अब नहीं करते, बिल्कुल नहीं करते. 39 वीक से पहले छूना भी नहीं चाहते, पर 39 वीक्स में जब पीवी करते हैं तो कौन सा जना स्ट्रिपिंग नहीं करता. अब उसको तुम इंडक्शन में इंक्लूड करोगे कि नहीं करोगे, you know, you are just hastening the labor. So at the end of the day, we have to take a very judicious decision with respect to that patient. अभी कोई जना insist करे कि नहीं मुझे तो कराना है cesarean, तो कौन obstetrician अपने सर पे लेगा ना, इसको कुछ हो गया तो तुम तो गए. So we have to actually weigh every patient, but yes, ethics will always take us farther. Thank you so much to be here for this debate.
Being a last session of the day, can we have a round of applause for all the speakers and judges? Thank you so much for the debate. Yeah, after this 6, 2, 4, 6 people. And that's all we have from Kautaliya Hall today on the day 1 of the scientific program. Don't miss to meet at the evening culture program, and rest of the scientific program we will resume tomorrow. Once again, I would like to thank Dr. Niba Mohan and Dr. Once again, we would like to thank Dr. Ranjana Sinha and Dr. Charu Modi as conveners of the day 1 of the scientific program. Dr. Charu, thank you.